All right, good morning, friends and family. So one of the most important aspects of paramedic life is the ability to manage an airway. This is what separates you from the animal that is an EMT. Understanding the pathophysiology of respiratory diseases, understanding the structure, flow, and anatomy of the respiratory system, understanding how it takes chemical measurements to bring air in and it controls your respiratory rate, your tidal volume. All of that is important to understand. This will be one of the most important lectures I give you all year. That being said, because it's so important, every year I look at the book and I look at what it can offer us. And it's usually pretty good. It's got some comprehensive information involved in it, but I also find that it's lacking things that could be beneficial to you. It could be something as simple as a better picture or adding a video or other simple things like other information from other places. So this is what I call the airway management lecture. I have spent a couple years building this thing up, and it's not just my own musings. It's not just my own thoughts and feelings. It's also about 4 or 5 books added into one. So we had the Nancy Caroline Paramedic Practice 5th edition, the SLAM Conference Airway Management book, Fulton County Guidelines, and also my own personal experience of having gotten airways, failing at airways, learning the hard way on certain things. Part of what I'm paid to do here is give you kind of my experience. That way you don't do it. So if I was to say, hey, I touched the stove, ooh, burned me, you shouldn't do that. You can learn things the hard way, and some of you, I can look in your eyes and tell that that's just your way of living. I'm gonna touch the stove too. Ow! Why did I hurt myself? Why am I like this? But some of you are going to be wise. Wisdom is learning from the experience of others. Like Chamberlain saw me touch the stove. He saw me get burnt. He decided to not touch the stove. Good job. So today we're going to talk about airway, at least airway 1. So establishing and maintaining a patent airway and ensuring effective oxygenation and ventilation are vital to patient care. Why? We talked a lot about the cells and the cells needing 3 things. What were those 3 things, Martin?
Water, glucose, and oxygen.
Water, glucose, and oxygen. How do I get oxygen in the body? I suck it in with my lungs. I have conduits or pipes that are my nasopharynx, oropharynx, my trachea. I suck air in. And the ambient air around me contains how much oxygen? What do you think there, Kuhn? I would go with 20.84%. Round up. 21%. It's fun to get in a room full of firefighters and not 21. Every year, 20. Wait a minute. Hold on here, mister. I know what they told me in that class over there on the fire side. Fight me. So not only do we have to ensure ventilation, but oxygenation. If I can get you to buy into one concept this morning, there's a difference in ventilation and oxygenation. Ventilation is simply moving air in and out. To ventilate means to move air in and out. Now you have certain adjuncts that you can use to help you ventilate, like a BVM, like your lips. But if any of y'all needs mouth to mouth, I will let you die. I'll just tell you that up front. I'm not doing it. Chamberlain, you're real dead. So what we're doing now is talking about how you can ventilate, how you can get air in and out. That is a core concept, but oxygenation is the other matter. What is oxygenation? What do you think there? Stafford. Okay, so diffusion of oxygen molecules across the alveolar capillary membrane. So I'm adding more of a concentration. The question you have to ask yourself when it comes to patient care and what to do about a certain patient situation is, which gun do I fire? Is this a nasal cannula fix? Is this a intubation and I breathe for you fix? Is this a I need to nebulize medications like a beta-2 agonist fix so I can bronchodilate your lungs and allow more volume of air to come in? That is the question we have to answer, is that which adjunct do I need to shoot off today? for this specific patient, because each patient has their own unique needs. You have to kind of tailor the care you give to them based on what, Thornton? Assessment. Very good. 10 points to Gryffindor. So assessment-based treatment is what we do. Now, we have standard approaches to a lot of patients. Well, he doesn't feel good, so let me just put him on a cannula. Or we could do the old firefighter approach. He's breathing at 96% and just a little poorly. Let's put him on a non-rebreather. He's not breathing. Let's put him on a non-rebreather. He's dead. Let's put him on a non-rebreather. I can't tell you how many non-rebreathers I've seen patients put on for the willy-nilly of it. All right, I will call someone out. Not you guys for once, actually. A couple of years ago when I was in management, we had a medic in Forsyth County 911. Had a cardiac arrest he brought in. I was supervising, I was in the ER, and he brought him in, they're doing compressions. Oh my goodness. He had a non-rebreather on this patient's face. Nobody's bagging him. I repeat, they're doing CPR. CR. Non-rebreather on his face, no BVM. So based on the information you learned just minutes ago, is the patient being ventilated? No. Were they being oxygenated? Also no. Terrible. So we must understand there's a difference in ventilation, oxygenation, and we have to actually pull the trigger on the right adjunct at the right time. One of the big things, see, in the streets, it makes a difference, definitely makes a difference on which adjunct you use, because this patient may already be at CPAP level versus if we'd have got here like 30 minutes ago, nasal cannula might have handled this. The example I give is a congestive heart failure patient. If you'd have got there, sat them up at a high Fowler's, put them on a nasal cannula, they probably been all right. But they waited and called, and now they've went from respiratory distress to failure. And we're trying to keep them from going to respiratory arrest. There's levels to this game. Distress, failure, arrest. Distress is, I'm having trouble breathing, but I'm making it happen. Failure is, you have failed. You are failing to meet the metabolic demands of your body. Arrest is what? You're not breathing. So at each level of the game, you have to know which adjunct to shoot off. So if we'd have got there earlier, nasal cannula would have done it. I have fixed a lot of CHFers by sitting them upright, nasal cannula, and that was it. But we have graduated to what? CPAP game now. So he needs a bigger gun. He's already there. But that is based off of an assessment of that specific patient. And the registry is very famous for putting you in a situation and knowing if you know which adjunct to use. And discernment is not left from right. It's right from almost right. They like putting two answers that are obviously not really there. And then they have two answers that are super, super close. Super, super close to where you're going to have to decide which one's more right for my patient based on the information I've been given. But here is a lining of hope. The answer to the question is in the question. There will be characteristics in the scenario or whatever they give you that are meant to tip you off on which adjunct or which technique you need to use. I'll give you an example. You show up unresponsive male, shallow breathing. There was a term there. Shallow is meant to trigger you to be like, hi, I need to bag them. This is a ventilation issue. So the answer is in the question. Your goal this year is to learn how to break these things down and pull out and extract that information. And I hate that that's a part of this, but it is. Taking a test is a part of this. The road we must walk all year is between teaching you how to be a good street medic with what we have here in Atlanta, Georgia area, or wherever you work. And then it's also, you have to pass a test. It's called paying your dues. I'm not really convinced that National Registry is a real good measure of your competency as a paramedic. I admit that to you freely. However, these are the boxes we must check. The human body needs a constant supply of oxygen. It must have oxygen. What will happen to my cells if they do not get oxygen? They will switch to a different type of metabolism. What do you think there, Sloss? They will go to anaerobic metabolism, from aerobic to anaerobic metabolism. Very good. So if I don't have that supply coming in at all times, I will have a detrimental issue with my patient. They will start to slowly wean off to heaven, right? So the respiratory system, its main job is to bring in oxygen and eliminate carbon dioxide. Where does carbon dioxide come from? Metabolism, cellular combustion. It's the byproduct of the cells going through their process of glycolysis. So that carbon dioxide mixes with water, forms carbonic acid, and it travels in the bloodstream. Your job of the lungs is to do what? Breathe it out, blow it off, get rid of it. So bring in oxygen, get rid of carbon dioxide. If any of that's interrupted, you die, or you start to die slowly, or your metabolic functions will not work. Your vital organs will not function properly if they don't have oxygen. Why? Because cells make tissue. Tissue makes organs. Organs make organ systems. Organ systems make the organism. So if my cells that make up this organ are starting to switch to anaerobic metabolism, produce lactic acid, the pH of the body is shifting, I will have metabolic derangement occur. The organs will not function properly. What is one of those organs that will not function properly? Your brain. It has to have a constant supply of oxygen. I get these two confused sometimes, and this is my fault for not prepping better, but I'll tell you that the brain takes up about 20 to 25% of your blood flow at all times. And it takes up about 20 to 25% of your glucose consumption at all times. The brain will not go without. It requires a constant supply of this. If you don't have blood flow to your brain, what's going to happen to you? You will pass out. You will die. The brain cells will immediately start having dysfunction go on. So let's talk about where you come in. The failure to manage the airway is a cause of preventable death in pre-hospital setting. Let's talk about that. Pre-hospital meaning you. Failure is what you cannot let happen. By some mean, form, or fashion, you must establish a patent airway. Now, I have a order of operation. Is this oxygenation? Is it ventilation? I'll tell you now the little saying. If you can't intubate, you need to ventilate. If you can't ventilate, you need to intubate. And if you can do neither one, you must criconate, which means by some means, form, or fashion, I'm going to have an airway, whether I got to cut a hole in your throat and shove a tube down there, or here in Georgia, we can stab a big old needle, which is about as useful as a screen door in a submarine. But hey, half of nothing, it's nothing. Half of something, still something. But by some means or form or fashion, you cannot fail to get an airway, because if you don't get an airway, your patient dies. Plan A, B, C, and D. You line them up. When we talked about doing an IV, for the ones of you that were listening, I told you to lay out everything you need for a fight. So whether you get the IV or not, you've got your tape torn, your 1x1, your techoderm, everything for whether you get the line or you don't. When I go to intubate a patient, I could hold out my hand, and my partner would hand me the Mac 3, which is my preference, the tube size. He knew I wanted the tube size above it, the tube size below it, and all the other equipment I laid out for whether I got the intubation, whether I had a failed airway, whether I needed to use a supraglottic, or whether I needed to cric this patient. Because if you practice like you play, you will perform perfectly. And proper preparation will prevent your piss poor performance. What does all that mean? Is it a colloquialism, a saying, or is it something that could reign true in your own paramedic practice? If you set up the field properly, everything's laid out, and it seems like it takes a whole lot of time, but the more you practice laying it out, and it starts with you starting by checking off your truck in the morning. You get there, you know where the airway kit is. I put it there. I touched it. I checked the bulbs on the laryngoscope. You know how mad I'd be if I put a laryngoscope blade on the handle. I'm like, oh, the blade there's no light. That was on me to check it. Every blade I checked, every bulb I made sure was bright and was working. If you have a video laryngoscope, you would have checked to make sure it was in working order before you went into service, because it's not my EMT partner's responsibility to get an airway. It is mine. So I have to check. It starts with the checkoff. Everything is there that I need. I've got the tools to go to war with, because it could be quite an airway fight. You may not know that yet, but an airway fight can and will occur. You're fighting literally for this patient's life against maybe the own structures of their body, the own anatomy they have. Big, chunky woman with a bullfrog neck. You're fighting her own anatomy. She's got a way more anterior trachea. It's harder to see. She might be a Mallampati class 4, which we'll talk about later. This is your way of predicting a difficult airway. She may be really hard to intubate. You have to have a plan for that. It is a fight for her survival. A fight that I'm not sure you may be aware of yet that you're going to be responsible for, because you must understand the importance of early detection of airway problems. What does it mean to detect something early? To find it as soon as possible, because the first 30 seconds I spend with a patient, if we talk about primary survey, scene say, PPE, BSI, blah, 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 right after that, you form a general impression that it's airway, breathing, circulation. Primary assessment should take you 30 seconds or less. I should know within 30 seconds of meeting a patient whether that airway is patent, whether it's obstructed, whether they're snoring, whether there's gurgling, whether there's something I need to intervene on. If they're snoring, it's usually the tongue that's in the way. That's the most common airway obstruction. We can fix that with simple head tilt maneuvers. Do not begrudge the simple beginnings. Small stuff works. It really does. What else? If there's gurgling, suction. If there's stridor, which is a high-pitched crowing and whistling sound indicating a partial airway obstruction, there's something in the way. Is it their own tissue? Is it a gumball? Is it a kilo of cocaine that they tried to hide from the police? Now they have an airway issue. He was fine a minute ago when I was trying to arrest him. That happened to me once. I'm not kidding. I'm not sure if it was cocaine, but it was some type of drug. He got pulled over and he tried to swallow it and it got caught. So they called 911 and he's like, and I heard stridor. And he started to deteriorate. When I looked at his airway, I'm like, I got the McGill forceps. Interesting. Evidence, sir? You can't make this stuff up. Life is too funny. So early detection by you actually assessing your patients. As the paramedic, I do trust my EMT partners, but when it comes to certain things, I'm still responsible for it, and I need to check it myself. We talked about in pharmacology, measuring twice, cutting once, right? And there's no shame in the game, but when I pick up from, let's say, an AFD member, I'm going to redo the vitals, not because I don't trust you, but because I want to be thorough and I want to be accountable and I want a fresh set. When I go and drop off at the ER, what's the nursing staff going to do? Take immediate their own vitals. It's not to say I don't do vitals good or you can't take a blood pressure very well. Some of y'all. But it's to form a system of checks and balances to be thorough. So I have to detect these airway problems early. I have to be rapid and effective. So that means rapid and effective. Let's turn that into I need to be aggressive. What does it mean to be aggressive in regard to airway management? What do you think there, Chamberlain?
You can't be scared to do a more invasive approach if that's the best way to do it.
I really couldn't have said it better myself. You cannot be scared to do a more invasive technique. It will make you uncomfortable. Like the first time I cardioverted somebody, I was like, we're really doing this. This is really happening. Why'd that happen? There we go. It was scary. I'm about to electrocute a human being that's talking to me. It's uncomfortable. Digging in somebody's airway and throwing a tube down their throat may make you uncomfortable. But if it's what will save their life, you have to get comfortable with being uncomfortable. That is the whole crux of paramedic school. There's one of y'all in here that thinks I'm picking on you, right? I'm not picking on you, but I have to put you on the spot because any anxiety you feel in here will be very mild compared to a family asking you to dig in somebody's airway. Or like in East Point when they pulled a gun on me, better save my grandmama. Grandmama's got Frankenstein syndrome. She's stiff as a board. She's been dead for 6 hours. But I have to have an answer to this problem. Plan A, B, C, D. I cannot fail at getting an airway, whether I do intubation, supraglottic airway, or a needle crike or a surgical crike, whatever that means for you. Failure is not an option. You must detect the problem by doing a proper assessment, and you must rapidly, aggressively intervene. Get comfortable with being uncomfortable. And then continual reassessment. You ever rode down the street in Atlanta? You hit a pothole so hard it pops you back. Well, have you ever rode down the streets of Atlanta with an intubated patient? You hit a pothole so hard that unintubate your patient. So for it's boop, gah, the gawk gawk 3000 happens. So I'd intubated in the tube depth was at 21 centimeters at the lip. Now it's at 28, which means they have now deep throated my tube based on a big pothole we have hit. I wish I was joking, but it has happened. It has happened. So that's why we have to do continual reassessment. Another thing you need to think about is if you aggressively identify and treat a patient with an airway problem, it's a possibility they could wake the hell up and do better. If you ain't watching them, what they're going to do? They're going to pop that bad boy right out. And you'll be like, oh, no. Then he's going to be like, oh, no, I can't breathe again. Pimp down. He's back at it. So watching them to make sure that they're improving, but also make sure that they don't need to be sedated to stay under. That way you cannot have an extubation occur. Because what's going to happen is that bulb is inflated on that intubation, that tube, that ET tube. They pull it out. We're going to have some laryngeal damage occur. Some throat meat is going to be hurt. I don't want it to occur. So a lot of times we'll actually tie the patient's hands down if they start to improve too much. Don't get too much better, sir. Don't be getting too good here. When anybody let you wake up and sign a refusal, I got a bill for this. But secondly, I don't want him to extubate and I don't want him to wake up because that would be very traumatic for them. So appropriate airway management. We're talking about open and maintain a patent airway. How do you open an airway? Simple. You can do head tilt chin lift or a modified jaw thrust. When is it appropriate to do a modified jaw thrust? What do you think there? So possible trauma or spinal injury. Well, let's say you get to a patient that's unresponsive. They're on the ground. We can check them, but I don't know if they fail or not. It could still be a trauma. So I need to do a modified jaw thrust. I gotta be honest with you. It's not that effective. Not super effective. But a head tilt chin lift, that is going to open many, many doors for you. There's a lot to be said about positioning. When we played with the cadavers, when we had them for the A&P intensive, you saw how effective it was just to move that head around, right? To align the axes, and then you could actually visualize the glottic opening very, very well. That's still true. So opening and maintaining an airway. Recognize and treating obstructions. How do I treat an obstruction? What do you think there? Well, yeah. O'Neill. Remove it? How?
Is it something that is visible?
All right. So let's say it's visible.
You want to have your partner do one of them modified, not the doctor, but let's say get it out.
Okay. We're in the right realm of possibility. So if you can see it, you can try and get it. If you can't see it, we do not dig for it. Why? You will push it farther, make things worse. If you can see it, get it out. You see these? Your digits? Do not put them in people's mouths. Why? They might bite you. Ah! 9-fingered Chamberlain. So do not put your fingers in people's mouth. Do not finger sweep them. Use your McGill forceps. They can bite them all they want. But if you cannot see it, do not go digging for it. You would use McGill forceps to pull it out. Now, if they're conscious and they're like, oh, the universal choking sign, we could talk about Heimlich maneuvers. But you must recognize and treat these obstructions. Assess ventilation versus oxygenation status. What is the difference in the two? What do you think there, Martin?
Ventilation issue.
Okay.
There's oxygenation issue. I mean, you may have to breathe more, but it also could have some issues.
Very good. So ventilation, I've got to breathe for them somehow, some way, some form. Luckily, I've got this wonderful device called a bag valve mask where I ain't got to put my mouth on anybody. You've heard the horror stories about people giving mouth to mouth and they puke. Because let's think about it. You're bagging a patient. They're not intubated. Air is going in the trachea like you want it, right? Air is also going in the esophagus and the stomach like you don't want. It's only a matter of time for that gastric distension occurs, and all that air and that stomach contents comes where? Blah. This is why you probably need to make sure your service has an NG tube to decompress the air out of the stomach. You ain't got one. You've seen The Simpsons, right?
Yeah.
Okay, that's what I was going for. Couldn't get the tone just right. That's right. So that would be very uncool for you. But here's why I believe in intubating early, quickly, fastly, effectively. Intubation means I put a tube directly inside the trachea. I inflate a cuff. They're protected from aspiration. I can control their respirations, their ventilation, their tidal volume, all of that. I can control it. I can do that. And also, I'll show you on the mannequin and I even show you on a cadaver. Putting an eye gel or a supraglottic airway in, you can watch the lungs do this. Inflate a little bit. You do an ET tube, I get full alveolar recruitment, big gusts of lungs. There's a whole big difference in an ET tube versus an eye gel. Now, in a pinch, half of nothing, nothing. Half of something, something. Eye gel is better than nothing. King Airway is better than nothing. Combi tube, if anybody still carries it, is better than nothing. The Salt Airway, shout out to DeKalb, is better than nothing. One of their firefighters actually created the Salt Airway. What have you done, Atlanta? Nothing. Because all you do is think about yourself. So finding which adjunct to shoot at the patient based on their presentation will be vitally important to the success and survival of this patient. Administering oxygen. Some people just need a little O2. It's like me. If I was to go outside and walk up them stairs, I might need some O2 because I'm fat. It's okay. I accept myself now. What about providing ventilatory assistance? Can just any old ventilatory assistance work and do? No, it has to be the right amount. The right squeeze on that bag matters. The right speed matters. Oh yeah, it matters. So you can't just be overbagging your patient. You can't give giant gusts of tidal volume. The average adult, it's based on body weight a little bit, ideal body weight. But we're looking at about 500 to 700 being the average tidal volume for an adult. Bigger people, obviously more air, right? But average is about 500. You know that BVM can put up to 1600 mLs in? That's a lot more than the 500 we just spoke about, right? What could you cause? Barotrauma. We're popping, destroying, damaging lungs. What do you think the survivability is if you pop a lung? Absolutely poor. Like my finances, poor. So proper airway maintenance begins at the basic, most little level. It should begin with good positioning. Yeah, get in the right position. Does position matter? Chamberlain, hell yeah. You nasty. I'm trying to my airway and you being nasty. All right, I helped a little bit. So good positioning matters. How the tilt of the head is. I've had patients where I actually had to pull their head off the back of the stretcher and let it fall back so I could just see the airway because they were just so chunky. Also, hyperoxygenation. Why would I hyperoxygenate a patient before I intubate them? Let's see. Let's hear from, oh, you, DeKalb, that was late. Nobody told me. You're in trouble. TBI? Let's think. Hyperoxygenation is a good idea for a TBI to lower intracranial pressure, but I'm thinking more of the fact that I blow off nitrogen and I create a big oxygen reservoir for their body to use while I'm digging in their airway. Make sense? Kind of fit. In a way, we're kind of filling the gas tank so they have a little bit to go on while I'm actually going to dig in their airway. Now, that also brings me to another point that I'll probably hit several times today or this week. You got to give yourself a limit. Humility, I want you to have it now. You ever seen a doctor or a paramedic on scene dig in somebody's airway for 5 minutes and the patient not be breathing? It's disgraceful. And it's not about patient care. At that point, it's about your pride. Of course, I want to have the patient perfectly packaged. I want that ET tube. I look good walking in that ER. Patient's intubated. I got the meds going. Hell yeah, man. I'm good paramedic. But am I a good paramedic also if I gave myself 2 chances, I couldn't intubate, so then I moved to ventilating, then I got an eye gel. Am I still a good paramedic? I actually am. I didn't spend 5 minutes digging in the patient's airway while they were hypoxic. I didn't let my pride get in the way of patient care. I put them first. Have you ever missed an IV? Of course you have. You're going to have days you miss IVs. You know, there's days you're going to miss ET tubes too. Murphy's Law will track you down. What is Murphy's Law, John? Anything that can go wrong will go wrong. What about Cole's Law, Chamberlain? You don't know? It is a tiny cabbage dish. Some people enjoy it. I do not like Cole's Law, but some people enjoy it. I don't eat coleslaw. What is wrong with you? I did. I broke it up. It was a joke, for God's sakes. So serious. So serious. They thought it was like some new gas law I made up. Y'all are too easy. Never heard of this one. And here he is like, I don't know that one, sir. So back on track. The best interventions will be fruitless. What does it mean to be fruitless? Useless. We'll call it station 17. Is that your station? Moving on. Fruitless meaning that is useless unless preceded by effective basic control. That whole thing that we've been saying for years, it actually means this. BLS before ALS. Now there is a time and a place to where you just got to go ahead and pull out the big gun and go ahead. All right, well, here you go. There's a time for that. But the better choice and option and safety and effectability for your patient is to begin with basic airway maneuvers and then go to advanced airway maneuvers. Now, if you're already there and they're not breathing, they're in cardiac arrest, by all means, dump a tube. What size tube do you wear, sir? How may I assist you? Oh, this one looks like the perfect fit. So that matters. Now, what about the anatomy of the upper airway? Anybody remember anything about that? Airway structures are above the vocal cords. We're talking about the larynx or the epiglottis being the separator of the upper and lower airway. Epiglottis being the what? The tiny leaf-shaped flap that prevents food or water or spit most of the time from traveling down your trachea, causing you to have aspiration. Very good. So the epiglottis has a job. Does it do it right all the time? No. Does it try? Sometimes. But I know I've seen some of y'all walk down the hallway and choke on spit. So airway obstructions in the vocal cords. Above the vocal cords, we have the nasopharynx where the concha and the turbinates and the meatus are at. What are those guys' jobs? To warm, humidify, and optimize the air you breathe in. It also has with it pathogenic defense systems. What does that mean? Fights off stuff. Get out of here, old sawdust. I don't want you in my lung. Ha, got you, buddy. I'm gonna make you into a booger and get you out of here. That's about the truth. So the tongue must be manipulated. What does it mean to manipulate the tongue? Get it out of the way. Get it out of the way. That was gross. I'll never flick your tongue at me like that unless you're serious. Hello. See me after class for an extra credit assignment. So the tongue must be manipulated, which means the tongue's a lot bigger than you think it is. It will be in the way. Now, one of the things about the cadavers that is hard to get you to buy into is that the tongue is usually a lot more floppy. But these cadavers they're dead. They're stiff. There's no blood flow in the tongue. So it's not as in the way as it normally would be. When you start to actually intubate real patients, the thing gets in the way. So you must manipulate it. One of the first things we'll teach you is how to manipulate the tongue out the way and sweep it during your intubation attempt. Sound good? All right. So what does the word pharynx mean? Fancy word for throat, really. So the larynx is formed by the larynx. Why do you need to know airway anatomy? Why is it important to you? Oh, tube placement's good. What about if you're going to cut somebody's neck and dump that body in the Flint River? Wait. Kidding. I ain't in South Georgia no more. I left that life behind. So if you are going to be cutting somebody's neck with a surgical crike in a protocol-driven legal manner, or if you're going to do a needle crike, you must understand and know the anatomy of the larynx, of the cricothyroid membrane, of the Adam's apple. So let's take a look. The laryngeal prominence, the Adam's apple, which is the thyroid cartilage, will be that first little bump you got right there. Go on, grab your throat, give it a good feel. Most of you should have good prominent Adam's apples. Thornton, good job. Ashley. Sorry, don't report me. So please do. I would love some time off, actually. So the thyroid cartilage, we got the Adam's apple. Now, right below that, you should feel a little kind of plateau area that's soft and spongy. And then below that, you should feel the first tracheal ring. That'll be your cricoid cartilage. So in between the cricoid cartilage, this guy here, and the thyroid cartilage up there, there's the cricothyroid membrane. That is your site for needle crikes. That is your site for surgical crikes. Everybody can feel it?
No.
You got to push hard. Go through all that tissue.
Choke myself.
Yes, you could choke yourself. At least then you'd be quiet. Y'all paid for this. Remember, you paid to be here. Not yet. Some of y'all ain't paid. Give me my money. I got bills. So that'll be the site for that. Now, we talked about that. Site for emergency, blah, blah, blah. So let's talk about the money shot. Oh, yeah. Look at that bad boy. You see those? What's that? You said it out loud. So let's take a look. This area right here is going to be your glottic opening. That's the money shot. That's where the tube goes. Oh, yeah. Where the tube goes. I ain't say a thing. All right, look, it's behind me. It's on this screen. I'm doing the best I can here with the equipment I got. I'm underfunded. Actually, I'm not. I love everything I have. I know you're listening. I love you, Chief. You're the best. Give me a raise. The boys out. So we have landmarks here. Why do you think we have and need landmarks, especially around the glottic opening? What do you think there, Chamberlain?
It gives you a target.
Target. That's perfect. Target. And also this area could be damaged. There could be like a bad traumatic arrest going on or whatever. And a lot of that could be damaged. So having more than one landmark will help you find the area you need to be in so you can intubate. So you can take this patient's airway and save their life. So let's take a look over here. The epiglottis, we can take a look and see it's this leaf-shaped flap right here. His job is to do what? To flap over this thing and protect it during swallowing. Martin, you're the expert. Tell us about that. Nothing? No reply? That's a good move. Good move. Especially because I'm recording. Be immortalized forever. There's no telling how long I'll keep this recording. What class I'll give it to. If I put it on YouTube. Get to all kinds of places. So good answer. No answer is a good answer. So the glottic opening will protect you during swallowing. So what we got here is the glottic area here. The corniculate cartilage, the arytenoid cartilage. We're looking at all these things, the vestibular folds. Now these white lines right here are the vocal cords. You should be able to see the white V. That's your target. Go between. Stop it. I'm trying to run a serious class here. You disgust me, all of you. It's like a room full of toddlers. You farted. I know I got a 3-year-old. That's her favorite thing. Daddy, I tooted. Of course you did. I felt it. You waited until I picked you up, didn't you? Uh-huh. You're a nasty little girl. Nasty. Got time for this. So That's the money shot. So this is where we're looking for. It's not going to look the same on everybody. Why? Anatomy's different. Some people got bullfrog necks. Some people have things in the way. Don't point at him. That's not nice. So the trachea immediately descends into the thoracic cavity. The trachea is not a straight tube. The trachea is not a straight tube. John, what does that mean? You know about not straight tubes. Anything?
Sorry.
Nothing? No reply? Nothing to immortalize you on a recording about you knowing all about straight tubes and throats? Okay, good move. Good move. I'm sorry, but this whole PowerPoint's full of, ammo for me. So why do I need to know it's not a straight tube? Because there are times when you putting a straight ET tube down this person's throat will not work. A lot of times what I have to do is I put a hockey stick on the end of it. That way I can curve it into the trachea. And everybody is different. Get everybody, like, hey, everybody, but body is, shut up, it's funny. Everybody is different. So sometimes you may have to, I don't want to say MacGyver some things, but you may have to have a plan A, B, C, D, like we said earlier, to get this ET tube in the right hole, in the right spot. And that means you have to actually visualize your patient's airway. Intubation should not be like thing like that. I personally will visualize and look at that thing and then make a plan. It's just like, oh, there's a hole, there's a tube, blah, blah, blah. I take a look at the topography of my patient's airway. My first look is just that. I'm making a plan. I'm also determining their age, their sex, their size. Would I give the same ET tube to a midget, like, why are you gonna say Thornton's name while I was looking at her? Yeah, somebody that's not as, vertically great. Versus like Shaquille O'Neal. Y'all gonna get the same ET tube? No, because the tube that, if you got his tube, it'd go to your toes.
That's appropriate.
Is it? You paid for this. Some of you have paid for this. So basically what I'm saying is that you can't give everybody the same tube. You have to kind of measure. You kind of have to know. When we talk about pediatrics, there's actually a formula for gauging tube size, which we age plus 16 divided by 4. There's other ones too, but that one's really accurate. Also, for peds, if their little pinky finger is this big, should you give them a tube this big? No, it ain't gonna fit. Another gauge is the size of their nair or their nose hole. It ain't gonna fit down their throat. You have to gauge and make a plan and see what's working, what's not working, what will happen. More on the trachea. Oh, so remember that it's divided left and right. Right lung, left lung. The right lung has 3 lobes, left lung has 2. Why? The heart and the great vessel in the way, so it has the lingula, meaning little tongue, in the way. So the trachea and the main stem bronchi are lined with what? Goblet cells, or as we call them, goblin cells, because they produce mucus. They're snotty. What is their job? To trap debris, to make lung butter, to trap debris. The cilia are hair-like projections that sweep fluids and particles out. When you cough, what do you think's happening? The cilia are doing what? Hi-ho. Hi. It's trying to heave it out. An irritative reflex of the lower airway is called a cough. Irritative reflex of the upper airway, sneeze. It is your body's way of doing what? Getting it out of there. So the nose does the same thing. It has mucus in there that traps debris. The hair-like nair fibers, the hairs do what? They hold it. And then you do what? Shoot it out of there. Like a sniper. Nasty. Or you might be proper and have you a pocket handkerchief. Winston, here. Dispose of this. They're also lined with beta-2 adrenergic receptors. We talked a lot about that in where? Pharmacology. Now, what are beta 2 adrenergic receptors going to do for me? Baker. So relax the smooth muscle. And if I activate them with an agonist, I'm going to bronchodilate, allow more air to come in. Very good. Was you actually paying attention in pharmacology? All right. Won't he do it? So the lungs consist of smaller and smaller airways. The trachea, think of it like the big tree trunk. The bronchi are the big tree branches, and these are only conduits for air, which means what? They only just let air flow. But the bronchioles, they have smooth muscle. They can expand, contract, what do they need to do to let more or less air in? The alveoli is the actual functional site for gas exchange. That is where all the magic happens. Anybody used to watch MTV Cribs? That's where all the magic happens. Oh, yeah. So that's where the stuff goes down. That's where gas exchange occurs through that single endothelial lining of the lungs. And the lungs expand to increase the surface area of the lungs. What does that mean? Small area, small gas exchange. Lungs expand, big area, more area for what to occur? Gas exchange. You feel me? Yes, Josh. Very good way of explaining it. We love you. We should call and say this should give you a raise. Yes. Yeah. Yes, I agree. They're also lined with a phospholipid compound called surfactant. That usually starts being produced around week 30 of being in the mom's belly. Now, what happens if you have a preemie that is born without surfactant? They're going to have issues keeping the alveoli open. Very good. So take a look at the alveoli. We've got smooth muscle wrapped around them with elastin fibers. We've got the alveoli and the capillaries surrounding them. Capillaries and oxygen coming in and out. So what is that process called with air coming in and coming out? Respiration, but also the process of diffusion occurs where it travels from air of higher concentration to lower concentration. O'Neill, how much of this air is oxygen? 21. Cool. You know that from fire. Okay. I know how to drag hose, spray water on hot stuff. Man. You know, concrete and sprinklers does your job. I'll be clear about that. Look at these building codes, making where you can't do nothing but sit around a station and lift weights. So I'm not jealous. So capillaries, they have a job too. About 21% of the air is oxygen. You're right. So how do we know how much to breathe? Are you sitting here deciding like, I want to breathe this deeply? Delicious oxygen. Chemoreceptors, let's talk about them. You have central and peripheral chemoreceptors. The central chemoreceptors are located in the medulla oblongata, which is also where alligators are so ornery. Mama's wrong. You're right. Mama's right. So the medulla oblongata and the pons, that's the center of respiration in the brain. It's chemoreceptors, central because it's located in the brain. Chemoreceptors, they sense chemical changes. What does that mean? So in the cerebrospinal fluid, we're sensing changes in the pH of the cerebrospinal fluid. As the pH drops, the body becomes more acidic. It notices that the CO2 levels are climbing. CO2 is acidic. So as the CO2 rises, the pH falls. We have an opposite going on. CO2 levels rise, pH falls. So won't breathe, won't breathe, won't breathe. As the CO2 levels rise, your body knows to eliminate CO2. So it decides how many breaths per minute you need and how much tidal volume you need to breathe in and how much air you need to breathe out with each breath to maintain homeostasis. Oh, yeah. Everybody following me? Everybody lost? Cool. So the peripheral chemoreceptors are located in the carotid bodies and the aortic arch. They're sensing changes in PaO2, which is that partial pressure of O2, how much oxygen content you got. And they're also sensing blood pH levels. It's helping to do what? Help decide how much air you need, how big a breath you need to take, how many breaths per minute you need. Anybody lost on that so far? So if I was to say later, hey, who controls respiration? Sloths, where would you get?
Central chemoreceptors, peripheral chemoreceptors.
Okay. So central and peripheral chemoreceptors. Great idea. So what about patients that have developed chronic obstructive pulmonary disease or COPD? COPD having two different ways that can come at you, either with chronic bronchitis or emphysema. That's pink puffers versus blue bloaters. So in a nutshell, emphysema patients are ones that have really, really baggy lungs. They have chronic CO2 retention. They have to do pursed lip breathing. That's right. They breathe like that because they're creating back pressure to keep their lungs open. So COPDers with chronic bronchitis have chronic inflammation and chronic mucus production. They're just full of phlegm and fluid. They are, again, having chronic CO2 retention. They burn out those chemoreceptors in the medulla oblongata. Why? The CO retention. If that CO is, if it's measuring CO2 levels and adjusting what you need to breathe based on those levels, and you have chronic retention, what's that going to do to the receptor? It's going to burn it out. So they'll switch to what's called a hypoxic drive. Hypoxic drive, which means they have trouble eliminating carbon dioxide, so they have higher blood levels of CO2. That'll alter their primary drive. So they use a backup drive. Hypoxic, hypo meaning what? It's a prefix indicating direction, intensity, location, or color. Hypo meaning low, not enough. So oxic meaning oxygen. So they're not going to breathe until when? The O2 levels drop. That's why most of them have a normal O2 set of around 90, 91%. They're not actually taking breaths until when? They hit that level of breathing. So providing high concentration oxygen over time will increase PaO2. What could that do for your patient? Kill the respiratory drive. They become altered. Why are they altered? Because they're not breathing. Now, other things that can affect your ventilation control. Y'all need time to make notes? Y'all good? All right, I'll give you a second. Play on my phone. Come on, I'll wait for you. Other factors would be what? Can you name some off the top of your head? Make you change your respiratory rate. How about fever? A fever will increase your respiratory rate. Why? Because the basal metabolic rate of the entire body is doing what? Increasing. Certain medications, like, those, of course, excessive amounts of narcotics and benzos can decrease and depress your respiratory drive, but certain medications can affect your respiratory drive. What about hypoxia and acidosis? Think about the patient in diabetic ketoacidosis. What is their normal breathing pattern now? Rapid and deep. So they're in Kussmaul respirations. So the body can have other things that control ventilation, but the body's always attempting to maintain homeostasis. It's attempting to maintain homeostasis. Is it always able to correct? Is it always able to correct the issue at hand? No, but it will try. Next, we can talk about the dreaded oxyhemoglobin dissociation curve. You've heard me mention this a few times, kind of in passing, when we're talking about certain things such as cold IV fluids causing a molecular shift in patients' bodies. So the oxyhemoglobin dissociation curve is a sigmoidal S-shaped curve that represents the percentage of oxygen and hemoglobin that are bound together. So shifts in the curve are normal in certain areas of the body. Like when you go work out and you're pumping them weights. Oh, yeah. Weights get you dates. Curls get you girls. Oh, yeah. That's a normal shift. But a global shift throughout the body in either direction is not good. A right shift decreases the oxygen's affinity for hemoglobin. What does it mean to decrease affinity? I don't love you no more. You broke my heart. Be gone, Cheryl. I need to call her.
This is
What? What?
the slide.
The slides? Yeah, you can have them. I made them for you. So a right shift decreases the O2's affinity for oxyhemoglobin. So let's take, for example, like a good example I like to give is my ex-wife when she was still my wife. Amazon packages every day. Every dang day. Why do you work 3 jobs, Josh? What's I doing on TikTok? So what about decreased affinity? That means a right shift would mean that she's ordered this Amazon package, but it's delivered to a house way before mine. Like I live at 200 something road. It's delivered at 100 something road. It never makes it to the target, which is me, because it's lost affinity. It cannot hold on to the package very long. The O2 molecule cannot be held on to. Now, a left shift will increase the O2's affinity for the hemoglobin molecule by a lot. So that example means that she orders Amazon. They bypass my house, turn around the cul-de-sac, and then take it on back to their house. It never reaches its destination because it never lets go of the package. It never drops the O2 molecule off at the cell waiting for it. That makes sense? So right shift, decreased affinity. Left shift, increased affinity. So what about a patient that's been in cardiac arrest and is probably in metabolic acidosis? Can you assume is happening? So in the acidic environment, the hemoglobin molecule has way less of an affinity for the oxygen molecule. What does that translate for you? If you cannot correct the acidosis, if you cannot correct the cardiac arrest, the rhythm issue, you cannot save the patient's life. One of the H's and T's we'll talk about in ACLS is hydrogen ions. We're talking about reversible causes. H's and T's such as, let's say, hypoxia is why they're in cardiac arrest. Hypoglycemia. Hydrogen ions, meaning they're acidic as crap. How about T's? Trauma, toxins, thrombosis. There's a lot of different reasons you would be in a cardiac arrest situation, and one of them will be hydrogen ions. And if you've been down a while, you are acidic. Depends on your protocol, and depends on if your protocol allows you to give bicarb to alkalize the system. Haven't looked at it in a while, but it may have it not in there. What's that? Y'all can? I'm gonna look at AMR doing something. Y'all don't even carry a presser.
Oh, glad I don't.
All right, the cab. Over there. Get back in the cab. AFD business. Y'all carry a presser because y'all proactive. You don't carry anything. You'd have to make a nasty, dirty epi drip. Better than nothing. So acidosis and increased carbon dioxide levels can shift the curve to the right. What does a right shift do? It decreases affinity for the O2 molecule. So hemoglobin gives up the O2 faster. So carbon dioxide levels can affect this curve. Now, alkalosis and decreased carbon dioxide levels can shift the curve to the left. A left shift does what? It increases the affinity for oxygen molecules. And the hemoglobin holds on to more oxygen. Will not let it go. Now, what are some normal causes to a left shift? I include this for you because when I retook the registry in April 2020, every couple of years I'll take the thing and look at it. There was questions about a left shift on the National Registry. And this is stuff I didn't learn until I was in critical care school and flight school.
Hyperventilation.
So if the problem is a carbon dioxide problem, you could blow some of that off. That's a good idea. That is a good idea. So let's talk about a left shift. Oh, Jack. There was room for both of them on there.
They just proved it.
Did they? Who did? Mythbusters?
James Cameron.
James Cameron.
Go back 1 quick second.
Go back, all right. You good? All right. So a left shift. Cause of a left shift include high pH and then decreased, decreased, decreased. So a high pH or alkalosis, decreased temperature, so being really cold. Hey, wait a minute. What if you give those cold IV fluids to a patient that's in traumatic or that's in a trauma patient? What's that going to do? Come on.
Left shift.
Left shift. Decreased CO2 levels. Somebody that's hyperventilating, blowing off all their CO2. It's going to create a relative hypoxia. Why? Because their left shift is causing the hemoglobin to hold on too tightly to the oxygen molecule and not let it go. So they have a relative hypoxia that's created by that left shift. Are you following me? Loosely. Ish. What about 2 to 3 DPG? Decreased 2 to 3 BPG. That stands for biphosphoglyric acid. Biphosphoglyric acid. Where does that come from? Come on, Chamberlain. You were the one. I revoke your status as the one. I don't want it anyway. So that comes from cellular respiration. It's a byproduct of it. So decreased levels of that will do what? Left shift you. What about a right shift? The exact opposite. Causes in a right shift. Low pH, so acidosis, increased temperature, increased CO2, increases in 2 to 3 BPG or biphosphoglyric acid. So let's take a quick poll here. Does it get hot in house fires? Do people have trouble breathing in there? Really? You think that a right shift occurring because of increased body temperature could have an effect and cause another relative hypoxia? Because you've been in there too long? What do you think? Baker, I'm listening. Is it working? The one time a year y'all work? The one house fire y'all have per year? I don't have to take that. Could it be a factor to consider, though? What does your rehab and rehydration station look like at a fire? Is it adequate? Is it really there? Is it set up? Is it staffed by appropriately trained and understanding proficient paramedics? I'm listening. Pretty much go to the engine. Prayer. Have some water. Quit whining. Get back in there. Woo, it's job town, boys. Woo. I remember when I fought fire, it was like 10 minutes of fun and then like 2 hours of like cleanup and salvage. This is not a great trade-off here. So, who doesn't understand left and right shifts yet? Got a loose understanding? What you got, sir? It's gonna take a minute. It's probably new material.
I may have missed it, but is it physical shift or are you just saying that this is what happened?
So it's showing that on a sigmoidal S-shaped curve that the affinity changes based on certain circumstances that your body is encountering. So let's say you ever had a patient that's having like a heat emergency? They were trying to having trouble breathing. Okay. So as they're having trouble breathing or they're having trouble catching their breath because that increased heat their body was under caused a shift in that curve to the right, which would cause them to do what? Have a decreased affinity for O2 molecules, which means I want to deliver this oxygen molecule to Chamberlain, who's like, let's say he's one of the cells that make up the tissue in my finger. Just keep it simple. But I can't reach that cell to drop off this oxygen because I got butterfingers. I can't hold on to it. It doesn't make it to its target. So I have a relative hypoxia created by molecular shifts at the hemoglobin level. That makes sense? A little bit more? Depending on what circumstance, I'll be right with you, your body is put under, whether it's increased temperature, increased CO2, increased 2 to 3 BPG, or that your body is in an acidic state due to being in shock. If your body's in shock and you're in anaerobic metabolism, your body's producing lactic acid, what will that cause? That could cause a shift in the curve. What you got? I'm gonna hear him first.
So is, as far as the increase in temperature, is that at a specific point? So let's say I gotta run in 23-degree weather again. Is that at the lower end of the range for it as opposed to I gotta run in 98-degree weather?
So a lot of that would be subjective based on your level of fitness, your level of activity, the level of layers and clothing. There's a lot of variables to that, I would say. But if your internal temp reaches whatever it needs to reach for your body to make the shift, because your body would shift differently than his or hers, depending on where that is, that sigmoidal S-shaped curve, that shift would start to occur slowly. And it could also occur rapidly, depending on if you like cold IV fluids in a patient that's already lost a lot of fluid and blood that keeps them warm. Those cold IV fluids will impact their clotting ability, will dilute their clotting factors, will bust clots that already exist, and because of the temperature will cause that left shift to occur in this curve. So the body will have a increased affinity where it's not going to let go of the O2 molecule. It's mine. It's my precious. I won't let it go. That makes sense? There's a lot of variables at work here. You don't have to understand it all today. Just kind of get a groundwork on it and understand that. Matter of fact, the way that I saw this question on registry was this. All the following will cause a right shift in the hemoglobin dissociation curve, except increased CO2, increased 2 to 3 BPG, low pH, or decreased temperature. Which one is it? There you go. That's how it was structured. That's how I saw it. So just understanding that they're at a molecular level, these patients that are not got a homeostasis are going to have certain other issues at a deeper level. Could make it harder for you to resuscitate them, could make it harder for you to bring them back to homeostasis because of this and this reason. So let's take, for example, you got a homeless man who's hypothermic, freezing his nubs off. Hello. And you got him out there and he's having an asthma attack. He can't breathe. He's already having an asthma attack, but he's also freezing. He's hypothermic. Do you think that's going to help him or hurt him based on the information you have now? Hurt. So you should then remove him from said environment, warm his body up, and bring that curve back to where? Homeostasis. You dig? I like it a lot.
So this has a lot to do with people that are anemic.
Ooh, anemic people are a whole different ballgame. They have respiratory relative hypoxia based on a lack thereof of hemoglobin molecules, so kind of similar, but also red blood cells to transport it, depending on the type of hemophilia they got. There's also microcytic anemia where they don't have enough iron, and iron's what holds the O2 molecule to the hemoglobin. So there's different types of anemia, but basically their problem is they can't transport oxygen in great supply. So how do you treat somebody that's anemic? A lot of times they have a blood transfusion. How do you treat a hemophiliac where they're missing clotting factors? They can have a blood transfusion. How do you how do you actually treat a sickle cell patient that's sickling? Blood transfusion. That makes sense? How do you treat a patient that's had a bad trauma and lost blood? They need blood. You lose blood, you need blood. Everybody feeling good? Let's go back and refresh something. Respiratory and cardiovascular system work together. We could have, though, what's called a VQ mismatch. What is that? Ventilation perfusion mismatch. I'll give you an example. With a PE, there's a clot blocking blood flow to the lungs. Not a ventilation issue, though. Air is coming in and out. Great. But the blood circulating through the lungs, not great. Let's say Chamberlain falls into a pool this afternoon, starts to drown a little bit. We're going to get him out and save him, of course. But there's now fluid in his lungs. There's water in his lungs. Blood is circulating fine throughout his pulmonary tissue, right? But can you breathe through water? No, there's a VQ mismatch now. So they have to work together to bring oxygen in, bring nutrients to the cells, remove waste. What is the waste I'm removing? Martin, what you got? CO2. What is important about CO2 in my respiratory drive that I should remember? In my chemoreceptors. I'm asking you.
Too much.
What's driving my respiratory drive right now?
Your chemoreceptors.
My chemoreceptors, and they're basing their data off of what factor? pH and CO2 levels. pH drops, I'm more acidic. The body wants to regulate my pH levels and bring it back to normal levels, so it blows off CO2, which is acidic. So again, pH drops, CO2 rises, breathe. Breathe to maintain homeostasis. Tell me again about ventilation. It's just simply moving air in and out. Oxygenation, loading more molecules on the hemoglobin. And respiration, that's bringing in oxygen and getting rid of CO2. I'm going to have that repeated a few times a day until you lock it down. Ventilation is simply moving air in and out. Oxygenation is putting more O2 molecules in there. Respiration is the exchange of O2 and CO2. Gas exchange. Through what process does gas exchange occur? Johnson. Diffusion. I like it. I like it a lot. It's one of those things. How much more painful can I make this? How much more harder can I drive this point home about ventilation being the act of moving air in and out of the lungs? What device do you carry that can actually reenact that? What do you think? A BIVM? BVM? Does it matter how hard I bag?
Yes.
Does it matter how often I bag?
Yes.
Why? If I blow off too much CO2, would that cause any kind of molecular problems for a patient? Any kind of shifts, any kind of curves we talked about? Very good. So 2 phases: inhalation, which is active; exhalation, which should be passive. You must ensure adequate ventilation. How do you do that? Well, how do you calculate a patient's minute ventilation?
Tidal volume times respiratory rate.
Tidal volume times respiratory rate gives you the minute ventilation. How many milliliters of air are coming in and out? How many liters are coming in and out? What do you think the average blood volume for most patients is? Between 5 and 6 liters. What do you think the average minute ventilation for a patient is? Between 5 and 6 liters of air. It's pretty close there. Again, it's depending on your activity level, your size. Like the gentleman you was talking about earlier in that other EMT class. He's just sitting there talking to you, snoring while he's awake. That guy might be moving a tad bit more air than you. So oxygenation, we're loading O2 molecules on the hemoglobin. Requires an adequate fraction of inspired O2. This is the FiO2. This is a figure you'll see when we're talking about vents and when we're talking about more O2 molecules, more bang for your buck. So oxygenation is the fraction of inspired O2. What percentage of oxygen are you actually getting? Right now, what percentage of oxygen are you getting, Martin? 21% is right. If I put you on 100% O2, though, what are you getting? 100%. God dang genius, boy. You going places. So respiration, we talked about being what? The process of just exchanging O2 and CO2. In comes O2, out flows the CO2. I bring in oxygen to feed cells. I'll then do what? Get rid of CO2, which is toxic to my body. Anybody ever sucked on a tailpipe of a running vehicle? Why not, besides sloths?
Not intentional.
It'd be deadly to you, wouldn't it?
Eventually.
Eventually, yeah. Because the product of that fuel breaking down in the engine, its combustion is that carbon monoxide. The product of your cells going through the glycolysis process using the oxidizer, oxygen, is what? Carbon dioxide. Therefore, over time, if it builds up in your system, it will become toxic to you. You will become acidic. What happens in the acidic environment? What do you think there, Tyler? You did not? You weren't paying attention? What a terrible student. Someone throw a rock at him. Okay, so if you're not breathing adequately and the CO2 levels are rising, that'll cause the environment to be more acidic. What kind of issues could I see happening there, Chamberlain, if I was thinking about it from a molecular standpoint and a affinity standpoint?
You would have the right shift and
A right shift is
you
correct.
lose affinity.
That's correct, sir. A right shift would occur and I would lose affinity for oxygen molecules. So I already am having trouble breathing. I'm holding on to CO2. Now I'm going to have an issue with my hemoglobin actually holding on to the oxygen molecule. Seriously? It's a domino effect. So disruption of pulmonary ventilation, oxygenation, and respiration causes immediate effects. We went back to saying you must recognize these issues and airway problems immediately. Why? Because time is tissue. Time is money and time is tissue. The longer that tissue goes without blood flow, oxygen, the more problems these patients are going to run into. So what does it mean by time is tissue? What do you think will happen in a few minutes? Okay. Infarction, meaning tissue death. So about 0 to 1 minute, we're looking at, let's just look at it. Cardiac irritability. What happens when the cardiac meat becomes irritated? You'll see PVCs start to appear, premature ventricular complexes, which are indicating there's some tissue over here in the ventricle that is pissed off. I want oxygen. I want it now. It's your money. Get it when you need it. Oh, gee. Oh, God, it's stuck in my head. It's already there. If you have an annuity, damn it. I'm sorry. You guys are screwed now. Need cash now. All right. Get out of there. Get out. Devil's a lie. So cardiac irritability. We've got that ventricular meat that's pissed off. It's his oxygen. I want it now. So what's he going to do? He's going to increase his automaticity. So this ectopic foci will create enhanced electrical power and cause spontaneous depolarization of the ventricular myocardium. What does that mean? The heart will be forced to beat early, out of sync. An early beat. So this could cause PVCs to turn into a run of VTAC, ventricular tachycardia. That pacemaker cell could take over. Or you could throw PVCs daily, just like walking up the stairs, and it's not a big deal. But for someone that is going without O2, for someone that is actually in a low perfusion shock state, or a respiratory failure, arrest state, the first thing that's going to happen within 1 minute, cardiac irritability. In 0 to 4 minutes, we got brain damage. Not likely, but we have the tissue becoming ischemic. We have ischemia, injury, infarct. Ischemia means I'm just low O2. Injury means the tissue's actually being damaged. Infarct is dead meat. Does dead meat beat? No. Does it contract? Is it excitable? Does it conduct electricity? No. It's worthless. Like station 17. What? What do you want, training center boy? You didn't got a station. Sorry, that was mean. True though.
I do have a station.
You do?
That's kind of been what's the difference between this example where somebody who's holding their breath for like 5 minutes all the way up to the record of like 17 minutes?
So that person conditioned themselves for that. They increased their lung capacity, their residual volume. They also practiced nitrogen washout, which allowed them to carry more oxygen reservoir in their lung fields. So nitrogen makes up about 79% of the gas we have in the atmosphere right now. It's too dense for us to breathe. So it's not useless though. Because it's so dense, it does have a job in maintaining alveolar shape and keeping them open. So nitrogen washout can cause alveolar collapse, but if you wash it out, there's more room for those O2 molecules to compound and sit there and be used. That's how they're able to do that. Make sense?
Without the brain.
Well, they're still having again, they have like, think of it like your lungs are like a tank for you. They have those O2 molecules sitting there, and he's holding that molecule, and he's mastered the art of like, kind of like a little balloon, like holding it as long as possible and using as minimal as possible. You notice they don't move much when they're doing it. Like they're just kind of just laying there. So they're minimizing their movement. They're probably in cold water to slow their vasometabolic rates. There's a lot of like little tips and tricks, I think, that makes that possible for them. And again, that was all a guess. So I don't know. But I feel like if you say anything confidently enough, people will believe you. It's all about your tone. Learn that. But I don't think I'm far off. So 4 to 6 minutes, brain damage is possible. Within 4 to 6 minutes, brain damage is possible, and it's very likely at this point. How fast is the average response time for a fire unit to get somewhere, Johnson? How fast you get into your calls? Depends on the call. There's a fire call. Minute 30 seconds. Med call 5:50. It's job town, boys. Woo! I ain't even always dressed. Oh, no squishing. It's not your fault. So 4 to 6 minutes, with the average response time in the US being about 4 to 8 minutes. That's the expectation. Contractually, a lot of places will sign on for you to have a 4 to 8 minute response time. Obviously, they want it as fast as possible, but I mean, I can't even pull my drawers up in like 4 to 6 minutes sometimes. You know what I'm saying? What if I'm in the bathroom? Oh, gotta pinch this loaf. Oh, let's go, boys. Don't act like it ain't a real problem. Don't act like it ain't. Like I'm the only human up here. Don't act like you ain't had to use the bathroom on scene on a fire call. Don't act like you ain't watered bushes before. Bunch of liars. You ain't peed off somebody's porch you don't know? You ain't really fought fire, have you? Am I lying, Chamberlain? Oh, you forgot. You don't pee on people's place. You have. All right. I remember back in the day, like before you took that obligatory fire call picture with everybody, especially in South Georgia, we ran one call a year. You know, dude lit his cigar with the burning house.
No.
I thought it was funny. Cap, what are you doing? Nothing. They frown upon that now, I think. What mama don't know won't hurt you. So every cell needs blood flow. Hypoperfusion is shock. Shock is hypoperfusion. So what we need for this patient is to do what? Make sure we can get to them as quick as possible. Make sure we can restore the balance possibly, but that's going to take an extremely fast but thorough primary assessment, and you being able to recognize this patient is not breathing adequately, or they're not breathing enough, or they're not breathing at all. Now, the book and the scenarios on paper, they're easier to figure out. Patient has shallow breathing. You read that and you're like, oh, triggered. Bag on BVM. They got cool, pale, slimy skin. The shock. Yeah. That's harder to feel in real life, though. It's harder to see in real life, though. Because I don't know about you, but the gloves sometimes mess with my sensitivity on my settings on my fingers. Is he really like, God dang it. Yep, he's cold. I don't know about you, but I've had to like pop the tip off of a glove before and just like check some things out. I ain't telling you ever to disregard your PPE, but I'm telling you it's a lot more effective if you ain't got that thing on. Stop it, all of you. I know. I insinuated though, and you just picked it up because it was subtle though. I'm proud that you could pick it up. Was it though? Ish. So we have to recognize and be aggressive. Recognize there's a problem, fix the problem aggressively. Have the plans laid out, A, B, C through D. Again, you're going to have your own preferences once you start intubating and start playing with them tubes and playing with them blades back there. Oh, you got another one? I said tubes. You got excited? Cylindrical object. Let me fondle it. Looking back there, smiling. Okay, good. If you didn't know, paramedic students are a bunch of like kids. Like toilet humor runs supreme in here. I can't help it. I just buy into it. I'm recording. Got my back on you. No. There's nobody on the Zoom. This is for you to watch later if you need it. Because let's say that you didn't quite understand the hemoglobin dissociation curve and you need to rewind me a few times. This is for you. Let's say I have a night EMT or paramedic class going on that I do recorded lectures on. Ooh, there it is. 2 birds, 1 stone. It's called time batching. Don't hate me for being the player. So hypoxia, break the term down. What is hypo? It's a prefix. What is a prefix? Martin.
Is a direction meaning color.
Okay. Y'all learned something in AMP. So hypoxia, oxia meaning oxygen. It's just the cells are not receiving enough oxygen. And depending on where they at, you can start seeing signs and symptoms like altered mental status. That's usually a late sign. Being restless, irritable, tachycardic, anxious. It's a very, very early sign. Like they'll be anxious and irritated like you ever been hungry? The brain craves food, water, sex, air, and sleep. If I don't get all of that, what? Hell yeah, I did.
I kind of witnessed that yesterday.
Uh-oh. Do tell.
Not sad.
No.
Talking about the monsters.
What kind of site are y'all running? This is called Only Medics.
The patient,
Oh.
I witnessed something when you talked about when her blood pressure, I've never seen 68/29.
60/29. So she probably developed some shock symptoms.
But guess what happened?
Well,
We elevated her legs. We put her all the way back.
you put them behind her ears?
We got her to the ambulance. Didn't give her no fluid yet. We're about to, it brought it up to 138.
Crazy how just positional changes can make a huge difference.
And she started, her color came back. And she was looking very blue, pale, while we were transporting her, walking her through. As we got her in the back, the elevator, and I'm like, oh shit, I see what you were talking about.
I like it. So what we were saying was a call yesterday at the airport. There was a young lady with a 68/40 blood pressure. They was able just to change her position, allow for more blood flow to, by gravitational flow, just go back to the vital organs, and she started to improve.
We did a line.
You did a line on her too. I like it. But the brain will crave those things: food, water, sex, sleep, air. And if it doesn't get them, I don't know about you, but if I don't get food, I get irritable. If I don't get water, hey, I'm recording. I'm saying the truth. I'm saying medically, your body craves what it craves in varying levels. I just ate lunch. Stop it. Jeez. There's a 40-year-old woman in here talking about she's craving that stuff. This is what I'm dealing with. I wouldn't deal with this at Grady.
Oh, Jesus Christ.
I am not.
Cougars. See, cougars have claws. They attack. I'll allow it.
Somebody had a heart attack.
So late signs, we're talking about what? A weak pulse, cyanosis. What is cyanosis? Turning bluish. I'm blue. If I don't get air, I'll die. Remixed. I'm blue. If I don't get air, I die. You don't like it? I think it's good. We could do that. Yep, we could do it. So air and blood flow must be directed at the same place at the same time. They got a date they can't miss. They have to be there at the same time. Blood flowing, air moving in and out. What is ventilation? Thornton, gotcha. Best pay attention, a squishy will get you.
Mhm.
Ventilation, if you please. Oxygenation, if you please.
Can you help the person?
Uploading his oxygen.
Okay, uploading of oxygen molecules, very good. Oh. So a VQ mismatch occurs when blood passes over an alveolar membrane without gas exchange taking place. What could impair gas exchange, Baker? Your mouth's open, but nothing's coming out. That's a good answer. Not breathing.
No,
But that was a good one.
Mucus plug? Mucus plug could get in the way of ventilation, which would cause a VQ mismatch. That's actually very common with patients that have a trach. And you actually have to learn how to use deep suctioning to pull that lung butter or that lung booger out. It's lovely and smells nice. Then you have to dip it in the saline and put it back in there. Now, yeah, I want you to imagine that. Oh, that's hot. So what's another thing? Carbon dioxide is recirculated into the bloodstream. How does that happen?
There's a gas exchange.
Gas exchange could be impaired by what? Let's say a chemical mediator brought on by the administration of delicious heroin or heroin, as we call it here in the dirty South. Heroin could depress the respiratory drive. So if you're not breathing it out, what's recirculating? CO2. You're becoming more acidic. In the acidic environment, acidosis, we're going to have a affinity shift, less affinity. I can't hold on to it so it doesn't get delivered to target tissues. You feel me? Yeah, boy.
I understand, I can't explain it.
You understand it, but you can't explain it. So you're in the right spot. Normally I pick on you. I'm gonna give you some grace today. Look at this. The initial a bit of this is that you understand it, and as time flows into it, you get competency, and then you can articulate it. Okay, so give yourself some grace. You're not going to understand all this. This is a lot of material. It's heavier than anything y'all had in EMT school probably already, and I'm not only 37 slides in. Like, I'm not kidding. I have 409. I'm 37 in because I will squeeze every bit of juice out of this one. Like last week we did the documentation. I was like, click, 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 click. This is important. Click, click, click. This is important, but not today. This is what makes you a paramedic. So if you're getting a grasp of it, you're in a good spot. Do not expect mastery today. Do not expect mastery for years. Expect competency by the end of this module. That's the goal. So give yourself some grace. You're in a good spot. So factors that affect ventilation. Let's talk about it. There's intrinsic and extrinsic factors that can cause an airway obstruction. Tell me about some of those. Intrinsic meaning something from the inside, extrinsic from the outside. So let's say intrinsic. A bee stings Chamberlain. Buzz, buzz, and then injects its venom in him. And he starts having an allergic reaction. What? I'm just in a mood. I'm good. I'm all right. I'll get right with you, sir. So what'll happen is he could develop what's called laryngeal edema. That tissue would swell because of the fluid coming out of the vascular bed and squishing his larynx closed. That is an intrinsic issue. It happened on the inside. Now let's say Sloss here. It's Valentine's time this week, and he's out on Valentine's night.
Why you gotta use sloth? That ain't sloth.
This ain't Sloss?
No.
I'm not judging, sir. I'm just saying, let's say some steak gets lodged in your mouth, some tube steak, and it causes an obstruction, and you make a sound, gawk, which is a sign of what? Which is a sign of an obstruction. That's an extrinsic sign from outside of the body. Am I right? It's assault with a deadly weapon. A deadly weapon. You paid for this. Some of you have paid for this. You paid to go to paramedic school. You could have went somewhere where there was a professional teacher. You chose here. So let's talk about some more. Intrinsic could be allergic reactions, infections. The tongue is the most common airway obstruction. The tongue is the most common airway obstruction. Tongue, the most common airway obstruction. If I repeat it 3 times, why is that important? I've seen it on a national registry. The stupidest questions, like, that is not something that I should have to figure out. That's not showing my competency as a paramedic. That is me recalling information from an airway lecture 8 months ago when we was in airway before paramedic school finished. But here we are. What you got, sir?
So, about the example you gave with the B, why couldn't that be an extra, because technically the B outside the body is presenting something outside the body.
It's not the B venom that's causing the allergic edema, it's your allergic reaction. Disproportionate immune reaction.
I see what you're saying, though. The B was the catalyst. So why is he not considered an extrinsic factor? Because he's the catalyst from the outside, but the issue that caused the obstruction came from the inside due to the histamine release. The degranulation of the basophils and the mast cells releases that histamine, which will cause, tons of metabolic issues like, let's say, bronchoconstriction, increased gastric motility, erythema, pruritus, urticaria. The fluid going out of the vascular bed and the vasodilation, big pipe syndrome, all that's coming from your body overreacting. So the laryngeal swelling, that's your internal issues that are clamping that thing. So I can see where you're coming from, though.
But food is going to be an extrinsic. Correct?
Yes, food is definitely an extrinsic.
What if they're allergic to food? Like somebody who's allergic to peanuts has pie and somebody sprinkled peanut dust over it.
Well, so I guess there'd be a difference between them having a peanut stuck in their airway, that would be extrinsic, and them eating the peanut, swallowing it completely, and having that cause
I'm good.
would be integral. We would say allergic reaction. Extrinsic is something like physically eating.
So what is ventilation? What is ventilation?
Yes.
Mechanical movement of air. What is causing the inability for me to move air in and out? So if a peanut is actually stuck in my trachea and causing me to not be able to ventilate, it is the fact. But if me swallowing a peanut, eating it, then my digestive system be like, ugh.
That would be
Intrinsic. You dig? So the tongue's the most common one. Other factors that would be extrinsic. What about trauma? Anybody ever had broken ribs in here? No?
Did you say trauma?
Trauma. So trauma and foreign body airway obstruction are definitely extrinsic. So it don't have to be a bee sting that swells your throat. It can be a house fire, smoke eater. You're not wearing your mask again, Baker. Eating that hot smoke. Sorry that 87% of your call volume is med calls. No smoke for you.
Burns, could it be both at times?
Yes.
Burns.
The burns are from the outside.
Reaction.
The reaction of the swelling and the laryngeal edema, that could be the intrinsic. What about trauma? You ever seen those movies where somebody gets punched in the throat?
Yes.
And then they just walk off? That's not realistic. No. If that trachea is collapsed, they're gonna have an issue. Oh, look, I get to crack today. So blunt trauma, burns, a lot of that can lead to. What about y'all hear about that EMS crew that transported a patient prone about a month ago?
Yeah.
So what is the problem with transporting a patient prone? What do you think they're? So we have traumatic asphyxia where their weight keeps the chest wall from expanding, which creates hypoxia, which creates acidosis because we go to anaerobic metabolism. Acidosis causes a right shift in the hemoglobin dissociation curve. Acidosis leads to more hypoxia. You see the domino effect. The patient will become altered. And the increased CO2 levels will do what? Further increase the acidosis, which will also do what? Yeah. Makes their own body toxic to them. Do you see the problem? We don't ever restrain people prone. Even like mall cops know that. Like, it's a thing. And strangely enough, when we get into med legal here soon, or when we do, we're gonna watch some court cases and some videos, and you can actually read in most departments, police departments, they're allowed to initially restrain prone, but then they have to stand them up or sit them up. Like, oh, we got you, sit up, buddy. That's a thing. It's gonna make you uncomfortable in here soon, but that is my goal. I can't always be the sage on the stage. Look at me, how smart I am. Man. I have to be the guide from the side and direct you and point towards the information you must make and draw your own conclusions. I want to teach you how to think. You don't need to think like me. Think like you. But have the information that'll affect how you can think correctly, especially having critical thinking, which is what? Chamberlain. Eat a ball.
Find critical things. Taking multiple factors and
Okay.
with an educated
Spin on it.
Yeah.
So making the best decision possible for your patient with limited information, that's critical thinking. And once you start doing that, you develop functional intelligence. What's that? Sorry, hit you in the hands. Twice.
Functional intelligence, being able to think outside the cookbook, connect outside the cookbook.
Very good. The cookbook will get you hurt. The cookbook will get your patient hurt. The cookbook is only there for the most minimal performing of you to make you perform minimally. The worst of us can always be like, oh God, what do? The book. Consult the oracle. Oh, protocols. There's nothing in here about this. What do I do with my hands? If you don't chew big red, then screw you. So we have to learn how to think in the gray. Other factors: hypoventilation, hyperventilation. Let's talk about it. Hypo, carbon dioxide production exceeds elimination. So you're holding on to too much of it. What could that cause? Acidosis. Hyperventilation, blowing off too much CO2. What can that cause? So carbon dioxide elimination can also lead to depressed ability to keep up with normal metabolism. What does that mean? Metabolic functions will be affected by too much CO2 in the body. It will be too much CO2. So we talked about if alkalosis is ensuing and the pH is too high. The pH is too high. What's the body going to do to try and save itself? Come on, expound on that. What's the body going to do if it's got too high a blood pH? You're alkalotic. Slow down your respiratory rate because it wants to maintain homeostasis. So now your patient's over there barely breathing like a guppy. That's going to happen. But is that really a good way for them to survive? No. Is that really going to allow their body to perform its metabolic functions properly? So then how can therefore, does that sound right? How therefore can I, the paramedico, take over this patient's airway and control it with perfect accuracy? Capnography. Capnography is the gold standard for resuscitation, tube placement, and airway and ventilation management. Ventilation is how much air you're moving in and out. It's how much carbon dioxide you are getting rid of. The true measure of ventilation, when we talk about cardiac arrest later, I'm going to tell you how it's the MVP of vital signs. You can measure metabolism, ventilation status, and perfusion status by capnography. Matter of fact, I'll show you and we'll talk about it, how if your capnography readings are not at least of a 10, your what's it do? Your compressor is not doing any compressions worth of poop. You have to have a certain level of capnography. So if your compressor is not even pulling out a 10 or a 15, they're not doing anything. They're either tired or wore out. These things don't lie. So capnography can tell me this patient's got a capnography CO2 level of 65. It needs to be between 35 and 45. So I need to do what? Blow some off, bring them back down. It's like hitting a moving target. I need it to be around 40, but between 35 and 45 is good. A lot of new medics are like, I don't know why he went back into cardiac arrest. I got the ROSC. Did you manage his capnography? No. You stopped bagging him as much. So the CO2 levels climbed, right? He got acidic again, causes metabolic dysfunction. You see the problem there? I don't know why I couldn't bring him back. Did you manage his O2 sat, his oxygenation at 94 and above? Did you think about that? No, you want to think about yourself, Martin. Did you manage his blood pressure at above 90 systolic, or at least a map of 60 to 65 to maintain his peripheral perfusion needs? Well, I couldn't get his pressure up. What'd you use? I gave him fluids. Ooh, you should have gave him a pressor to squish those arteries and bring the pressure up, make the heart beat harder and faster. Are you going to really work very well if somebody just pushes on you and beats on you for like 10 minutes, 100 to 120 times a minute? No, you'll be sore and beat up. I don't want to beat no more. I don't want this person to live. So those are factors you're going to have to consider. So what about factors in the ambient air? Can there be toxins in the air? Ooh, tell me about them. So carbon monoxide, right? Everybody, most of the people in the room are firefighters. Let's see, 1, 2. Everybody but you. I guess all the ambulance people be here tomorrow. So most of y'all, and even you probably should have heard that the affinity that carbon monoxide has for, it's way greater. Let me give you a good example. Chamberlain, you want $10? Sure, he'd like that. Martin, you want $20? I just doubled it. I just doubled the money I was going to give him. He loved it, right? That sounds like a lot. Doubling something sounds like a lot. The affinity that carbon monoxide has is 200 times. Think about that figure. What is 200 times 10? That's a lot more than $10. So that is a huge, huge metric. So other things we need to talk about is what closed environments where O2 decreases. Confined space rescue. It's a good thing we got all those special teams that get to use their skills all the time. What if there's swiftly moving water there? Is there a station that has boats they won't let me use to fish with here? Yes, yes, there is. Station 11. And their greedy boat captain. You got 3 of them. I could use 1. It's ridiculous. You could have a nice fish fry, but no. So other toxic gases displace oxygen. But what else could we talk about? What about carbon cyanide? What's that? Hydrogen cyanide? What is it? Carbon cyanide? Hydrogen cyanide? Whatever. When plastics burn, it releases cyanide. And most of the stuff we have in houses today are synthetic or made of plastics or microplastics. When it burns, it releases cyanide, which will cause the mitochondria of your cell to not produce ATP. It causes a secondary relative hypoxia. What are some signs and symptoms I could see? Blueberry. Honey. You ever seen that TikTok?
I have, but I'm trying to figure out how that's related.
You know what? I have a mind that's veered off. I can't help it. I needed less Celsius. So carbon cyanide. Tell me more about it, John.
It causes relative hypoxia because it displaces oxygen and then prevents your mitochondria from producing ATP. So just down your sodium potassium pumps and your body can't.
Very good. So in a nutshell, I can't breathe good. Correct. He dumbed it down for you. Anyway. So conditions that reduce surface area for gas exchange. Also, what about non-functional alveoli? Non-functional alveoli or alveoli that have become atelectatic. What does that mean? They've collapsed. What can cause alveoli to be non-functioning?
Too much.
Emphysema, good. Pneumonia can scar the alveoli where they're not functioning anymore. Ooh, I got such good equipment. I love it. So what about fluid in the alveoli? Submersion victims. What happens if you, oh Lord, get submerged in salt water? Let's say they resuscitate you. What is the salt going to do? Pull water from where? The rest of you. Look, you get to drown twice. Yay. Patients with pulmonary edema. Most common cause of that is congestive heart failure, secondary to a left ventricular infarct. Number one cause of CHF, left side of heart failure, is MIs. So exposure to environmental conditions or occupational hazards. You, a group full of firefighters, could be exposed to, what do you want, Whitworth?
I was interested, you have a abundance of saltwater pools. If you got them back,
Ooh,
what would you do for that?
what are you going to do about it? You want to guess? A what? So let's think about it. So if I give fluids, I'm going to increase preload, which will cause the heart to have a lot more fluid in it. And it's possible that the heart's function is not flowing well anyway. Is it possible that could back up into the lungs and I can make the problem worse? So let's look at your patient here. So if you couldn't hear her, the cab fire has a lot of saltwater pools in their fancy area, right? What do you do for a saltwater drowning? What's this? Ooh. What is this, Chamberlain? PEEP valve. What does PEEP do? Positive in expiratory pressure. It expands the alveolar surface area, and then that in conjunction with positive pressure ventilation, I can push air and oxygen molecules through that water and push the water back into the vascular system. I can force gas exchange to happen, and I can reduce the pressure. Excuse me, it'll increase the pressure on the right side of the heart, but I can force gas exchange to happen. I can make those O2 molecules go right through the water and force that to happen. So you could think about Lasix to move the fluid out, but again, Lasix is non-potassium sparing. But honestly, if they're drowning twice, they have bigger problems than that. So it's a lot to think about. But the main thing you would need for them is actually not a drug, not a technique. It is a CPAP, or it'll be a BVM with a PEEP valve, or it'll be you've intubated them and now you're controlling the airway, and with that positive pressure, you're forcing that to occur and to happen. Magical device. You don't have. Why? You're cheap?
People have to jump and understand the importance of it.
You lead them to water. It's like 30 cents, I think. I don't know. It's cheap as crap, bro. It's ridiculous. I hate all of you. Other factors. Hypoglycemia. Oxygen and glucose levels decrease. Infection increases metabolic needs. What's an infection going to do? Fever. Metabolic needs go up. Basal metabolic rate goes up. I breathe faster because I need more oxygen. I need more fuel for the body. Hormonal imbalance. What?
You're right about that.
I'm right about that. I know. I could sense it when you snapped and almost killed Baker earlier. His life flashed before his eyes. If you didn't know it because you can't see, she threw Squishy at him. Squishy is a deadly object. What else we got? Oxygen demands will not be met. If you don't have adequate perfusion, if you ain't got adequate blood flow, O2 demands of the body will not be met. It has a demand supply issue. So how much I want, which is how much I'm versus how much I'm getting. Nobody? I don't know. It's a good week for that, I guess. How much I want versus how much I'm getting. Think about the body and its needs. The brain gonna have what it's gonna have. If you give it what it wants, it's gonna pass you out. The heart gonna have what it's gonna have. If you don't, you're gonna start to have some chest pain, some ischemia, some irritation. How long does it take for ventricular irritation to occur? 0 to 1 minute. And then we can see PVCs or other type of arrhythmias occur. So obstruction of blood flow would also relate to trauma. If blood is not flowing to the tissue, it can cause damage. What happens if I was tie a string around my finger, turn red, blue, purple, black, and die? It's obstructed by a physical constraint. Let's drop a motor on Sloss's leg. What's going to happen? He's already crippled. No. Which one's your good one? I want the good one. Let's drop it on your leg. What's going to happen? Are you going to keep? So let's talk about heart conditions. Can a heart condition cause blood flow to tissues to be disrupted?
Yes.
Why? Let's talk about cardiogenic shock or CHF. It ain't got the muscle no more. I'm gonna leave that alone. I'm getting old too. So it ain't got the muscle no more. It ain't got the ability to make things happen. The spirit is willing, but the flesh weak, spongy. Shall not occur. So heart conditions to reduce blood flow to the tissues. So a poor functioning left ventricle. How about a decreased EF? What was EF, Thornton? Ejection fraction. So how much stroke volume percentage-wise I got coming out of that thing? Yep. You're too easy. So blood loss and anemia. If a patient's a bad trauma patient, they've lost blood, they're kind of anemic now, depending on how much they've lost, right? What's that going to do? Change their body's blood oxygen carrying capacity. They got less blood. Why is their SAT 88? I'm leaking, son. He shot me. Stop the bleeding. Yeah, tourniquet right here. Go ahead.
No, I
Try.
thought you were talking about the-
Try.
You can put that on. You have to burp it, but you don't have
We could do a 3-sided dressing, and then we can burp it.
burp it.
I like the
Inclusive dress.
inclusive dressing. I like the Asherman chest seals because they have built-in flutter valves. I think they're great. They don't cost much either, but y'all ain't got them. The cab got them. The cabs always lead the way with better equipment, better ingredients.
Domino's or pizza is better.
You know how you can
Oh,
tell?
I'm sorry. We're gonna have a discussion about pizza now instead of Airway. Acid-base balance. Remembering that acid-base is something that paramedics are responsible for knowing, and they've even got AEMTs responsible for knowing it now. In a nutshell, the balance is maintained by your body's ability to use buffer systems to keep homeostasis, whether it be your blood buffers, the respiratory buffer system where you breathe out CO2, or the bicarbonate buffer system used by your kidneys. Bicarbonate doing what? It'll bind to your hydrogen ions, bring them back to the kidneys, you'll piss them out. Again, if your body needs more acid to hang out, to stay at 7.35 to 7.45, it's gonna not bind to as much acid and let it free float around. But if it needs to be bound and to you to drop some acid, then the body will bind to it with bicarb and then you'll piss it out. So it either holds on to it or kicks it out. So it can be disrupted by hypoventilation. Why? You ain't breathing enough. So what'll happen? You don't breathe enough. What are you holding on to? CO2.
acid level.
So the acid levels will rise, changing the acid-base balance. Hyperventilation, blowing off all that CO2, you become alkalotic. Alkalosis is not a good thing either. And hypoxia can occur. Why?
Not getting enough oxygen.
What will high CO2 levels do to my curve? What? To the left? Right. Acidosis, raised temperature, raised CO2, raised 2 to 3 BPG. Left, alkalosis, lowered temperature, lowered CO2 levels, lowered 2 to 3 BPG. So that could lead to, again, a secondary hypoxia. So respiratory and renal systems help maintain homeostasis. We talked about that. Try to stabilize the body between acids and bases. Acidosis can develop if respiratory function is inhibited, though. Why? Something's in the way. Is it a physical, intrinsic, or extrinsic factor? Is it a chemical mediator? Is it a traumatic extrinsic? Is it the bee sting that caused an inside job, the intrinsic factor? Alkalosis can occur if the respiratory rate's too high. Why would your respiratory rate be too high? Georgia Tech boy. Oh no.
Anxiety.
Anxiety? Anybody ever had an anxiety attack? Too tough, right? I believe it. His generation didn't have anxiety attacks. They drank. They drank. They just drank beer, smoked Marlboro Reds. I'm down. Now we drink cold brew, iced. So I never had one until I started teaching full time. And I was like, because I used to kind of like, hey man, quit being a wuss. Get back in the truck. Like my partner used to circle the ambulance. We posted. What are you doing? Get back. You're freaking me out. Get in here. It's not that bad, man. I remember one time we had that bad psych patient. I think I told some of y'all about it, and it was a hell of a WWE match between me and this guy. And then at the end of it, my partner's fingers had carpopedal spasm because of the hyperventilation he had done. I'm like, I'm back there with a torn tendon in my back. I'm like, you're such a little thing. I'm trying to quit cussing. I'm been going to church. I get right with the Lord, and I'm recording. So alkalosis can be occurring by the respiratory rate being too high, a panic attack. And understand that, you ain't got to understand everything they're going through, but understand that right now everything feels overwhelming and they can't think clearly. Like normally you might be the most rational, sound mind person. But during this panic attack, anxiety attack, you may not think clearly. And everybody else can, look outside and see that, the rat in the maze is the rat in the maze. I can see how he could get out. But we're all different when it comes to our own problems, right? Let me give you marriage advice. No. How come all these single women won't give me marriage advice? Shut up. There's nothing you got to say. I'm gonna ask them. I'm gonna be the guy been married 30, 40 years. What did y'all do? That's what I want to know. But it's hard to see that when you're in the case. So an anxiety attack can cause respiratory alkalosis by hyperventilation. But hyperventilation, carpopedal spasms, could affect the calcium levels in your body as well. You could have some metabolic derangement occur. You got to slow them down, or God will. What'll happen if you keep hyperventilating? You're going to pass out. Then how fast you going to breathe? Very slowly, because your body's trying to do what? We got to get this guy back in order, man. Good Lord. Get the balance back here. Homeostasis. Whoa. So what happens if you go to that call up in fancy DeKalb where they got saltwater pools? I don't want to do my homework, Mommy. I'm going to hold my breath. What's going to happen? They're going to pass out. And then they're going to do what? Breathe really fast for maybe a minute, blow off all that extra CO2 they've been storing, and God Control Alt deletes them again. They're back to it. You ever run that call? First time I saw it, I was like, all right. Then I saw the kid go, I'm like, it's true. They do exist. So patient assessment. We talked about the quality of your care will determine the quality of their life. Is that any more true when it comes down to airway management? No, it's absolutely true. How good you are determines how good they gonna be. I'll say that again. How good you are at your assessment, treatment, and interventions will determine how good the rest of their life could be. Let's say they go 8 to 10 minutes without oxygen, and you've been there 8 to 10 minutes. That's your fault. One of the things that used to irritate the piss out of me was you go to a overdose patient and they've overdosed on a narcotic, and the first thing you don't do is to pull out the BBM. He ain't breathing. Fix that. But no, you're a medic now. Hey, look at this. I'm gonna draw this med up. Squirt, squirt, baby. Come on. The quality of your care determines the quality of their life or lack thereof. 8 to 10 minutes without oxygen. What's the brain gonna do? You're now a rutabaga. You're a beet, cucumber. What are all these things I'm listing? Vegetables. Can that be avoided? Yes. By you recognizing problems early, being aggressive in the treatment of those problems, which means doing uncomfortable things, and then doing a continual reassessment. What does it mean to do a continual reassessment? You don't know which one of y'all want it either. How about this? I know that the registry gives you figures. Reassess a critical patient every 5, and that's what the registry wants. No, you're right. You're right. And you caught it because you was looking for it. You caught it because you were looking for it. I know the registry says 5 minutes for unstable, 15 for an for a stable. That's good for paper. But in reality, if I'm back there with your loved one, let's make this real. You love your mama? You love your wife? I'm back there with your wife and she's having trouble breathing, Whitworth. Should I not only check on her every 5 minutes, or should she have my constant attention? Really? And why are we not giving our patients constant attention? My paperwork. I don't care about your paperwork. Do you care about my paperwork? Or do you care about your wife? Okay. So you are buying into what I'm selling you today is that constant reassessment. You know how I'm going to find it? Because I don't do anything else but patient care while I'm back there. That's hard for some of these medics to buy into. I got to get this piece. I might be late at the ER. I don't care. I don't care. You come from me. You are of me. You will buy into my methodology, which is you remember your wife when you run calls. You remember that if it was your wife back there, you would want constant attention, over attention. This is not a controlled environment. This is not an ER with 7 or 8 nurses and all these blinky machines and 10 doctors running around. This is me and you. Mano y mano. And as for me in my house, you're not going to slip one past me because I'm going to keep looking for it. Ooh, that was terrible, but I got it. As long as the results are the same. What about you, Harden? That's your wife back there. You like her? Most days? Oh my. At this point, it's either keep her or lose the pension. I mean, trust me, it's cheaper to keep her. So, should I give her my full attention or kind of ignore her, play on Snapchat? Full attention. I'm sure we could find somebody in here for all of you. Whenever you feel like pulling your phone out and playing on it, or just practicing documentation, remember this conversation. The quality of your care determines the quality of their life, whether they're a vegetable or not, whether you found the airway issue early because you were looking for it, whether you noticed that you hit a bump and that the intubation extubated, you found it early, you intervened early because you were looking. Patient assessment, airway evaluation. Let's talk about it. Assessing the airway. How do I assess if it's patent? I look.
Yes.
Are they talking? Are they yelling? Are they speaking in 2 to 3 word dyspnea? Is the patient unresponsive? Can I hear breath sounds? Can I look, listen, and feel? Looking for chest rise, listening for breath sounds. Are these things happening? Do they have an adequate open airway? Is there snoring respirations indicating the tongue is in the way? Is there vomitus in the mouth, which I need to suction? How long do you suction an adult? 15 seconds. Child 10, baby 5. Adult 15, child 10, baby 5 seconds. The problem with suction, you got to remember, is that you could activate the vagus nerve if you gag them, it's lost, and that will Brady them down. The vagus nerve runs from the top of your head to your butthole, and it is responsible for releasing acetylcholine. And if that acetylcholine is released, it will Brady the heart rate down. That could be detrimental, especially for a pediatric, but also the old man you got there on the table. It could kill him. Got to be very careful with that. And there's several ways to check for a gag reflex. The old-fashioned way was, yeah, yep, you got one. Now they've learned that the same reflexes or nerves that are associated with gagging, lost, is also associated with your eyelashes. If you have an unresponsive patient and you can tickle their eyelashes and they flicker, they have a gag. No flicker, no gag. Look at Sloss, no gag. I'm gonna have you a hell of a Valentine's this week. Whose is it? Whose is it? Your eyes looking. All right, I believe you. So vomiting, be careful. Gurgling sounds, also a sound heard during breathing. Is it from the upper airway where there's stuff in the way, or is it like a kind of wet gurgling you hear from the lower airway? So we have to find out that. Could be secretions pulling in the patient's mouth. Could be a lot of things. We got to look though. Do not put your what in their mouth? Fingers. What I don't. Even better.
Man, we still get gum, man. It's bone on bone.
So what I will teach you is what I call the fish hook. I'll show you what I mean later when we go to lab later this week. The fish hook is where I kind of just grab the jaw like a fish and I can open it up like that, and I can't get bit because my fingers are out the way. Also, it's a good way to get rid of trismus. What's that? Chamberlain. You been through paramedic school before?
Never heard that.
Lock, their jaws are locked. Like you can't open them, so you can break it with a sudden jerk like that. And if that don't work, Versa, woo, relax now. So what do I know about breathing? I need to assess and evaluate. 12 to 20 is a normal adult rate, right? Anything below 12, we're talking about it being bradypnea. Above 20, tachypnea. Do they have equal breath sounds? Is their chest rise adequate? Do they have a normal pattern? Let's talk about it. Is they responsible, able to speak? Do they have 2 to 3 word dyspnea? Is there any kind of intercostal muscle use? Is the depth adequate? Are they breathing deeply enough? Not just fast enough, but deeply enough. Depth matters. And right, Martin. What about pattern? What does pattern tell me? Watermelon. Coconut milk. Does pattern matter? Really? Tell me about it. I didn't think I'd get this far. I didn't mean for you to call on me. Okay, so pattern is indicative of a certain metabolic dysfunction that is occurring within the body. Can give me more diagnostic details. Right, very good. So Kussmaul points towards DKA. Shane Stokes points to a head injury and a possible increase in intracranial pressure. Biot's ataxic, central neurogenic hyperventilation all point towards head injury, brain lesions, tumors, things in the spinal cord, right? Now that's all well on paper, but you know how hard that is to watch and see in real life? Your boy ain't that good. What I noticed was irregular breathing, though. That's easy to see. So let's say we go to a MVC tree versus car. There's spider webbing on the windshield. The patient has an increased systolic blood pressure, bradycardia, and I can see they're breathing irregularly. May not be chain Stokes. I don't know, but they've got Cushing's reflex going on. They got widened pulse pressure, systolics through the roof, diastolics on the floor, they're bradycardic, and they've got some irregular respiratory pattern. I'm gonna go with this is a head injury, and they got an increase in the cranial pressure. Maybe you'll be better at recognizing the patterns, but through my years, it was hard to see them. I could see it was irregular or not. Another thing that would be hard is like if you ain't got a good stethoscope, we're talking about hearing a cricket fart from 3 miles away stethoscope, on the side of 75, you ain't hearing jack diddling. Not a thing. If you're going to spend money on stuff, make sure you spend money on stuff that makes you successful or safe. So good boots, they matter. Do good boots matter? What do you think, Cap? Absolutely. A good stethoscope matters. Having a good set of trauma shears matters. Like I gave away my gigantic shears last year. I had a student that had earned them. I'd had them for 12 years, and I finally met someone that I was like, here, take my sword. It wasn't all weird like that, but I was like, hey, carry these until you find somebody you think the world of, because I think the world of you. So he took the shears, and these were the giant Robin safety boys that were forged in Germany. Like these are some really big bad mamma jammas. I carried those Robin safety boys because one night I had a guy with 10 layers on who'd been hit by a car, urban camper, homeless guy. These couldn't get through his layers. They weren't good enough. So I'm not telling you go out and buy some Raptors, but you probably should better have something better than these. Figure it out. What about a good flashlight? That matter? Why? Seeing is mattering to you? Obviously, Whitworth, you wouldn't know that because you're blind. 4 eyes, you need glasses to see. Me and Tyler had LASIK. We're better than you, and we know it. I have perfect robot eyes. Definitely worth every penny. I suggest it for real. So clear and equal breath sounds. What can the breath sounds tell me? Is there fluid? Are they bronchospasms locked down? What else? The lungs. Is there a lung collapse? Is there a pneumothorax? Hey man, I don't hear nothing on this left side. Do you hear anything? Actually, I do not. If we both hear nothing, and there's a bent steering wheel, and he's got JVD and hypotension, we're looking at a tension probably. Tension pneumothorax, which we'll cover here soon, how to dart someone. I'll go ahead and tell you, when you dart someone, it stinks. You ever skin a deer? It smells like the inside of a deer. That inner chest smell stinks. Oh, I'm sorry. Y'all don't have deer in Ohio. You have mooses, caribou. You're not that far north? What do you got? Y'all got any kind of like deer-like animal? You have deer in Ohio? Interesting. I gotta get out more. Sounds like a happening place. Ohio. All right. So recognize inadequate breathing. So if they're breathing less than 12, find out why. Find out if they need you to help them. If they're breathing more than 20, find out why. Could be something as simple as he broke up with me. All right, so I know why. Because I would look at you, but a guilty dog, boy, it'll bark though. Quit tweeting about it. Get off the ground. She's emailing HR. This motherfish. So tired of him. You talking about I can't read good? So if they're over 20 breaths, find out why. It could be something as, hey, I was in a bad wreck. I'm a little excited. Could be some reason. Same thing with tachycardia. They're tachycardic for a reason. Could be excitement, could be anxiety, could be stress, blah, 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 but find out why. It ain't just happening for no reason. The body doesn't jump up to 25, 30 breaths a minute for no reason. The heart rate doesn't jump up to 120, 130, 140 beats a minute for no reason. Find the why. Again, it could be a simple why, but find it. What about cyanosis? They're turning blue. If they don't breathe, they will die. So what about preferential positioning? What does it mean, preferential? Preference. Putting someone in a position that they feel they can breathe better in. Does it hurt you? No. Well, our protocol says, actually, that always annoyed me about some of these medics. You gotta learn how to bend with the wind, flow, and go. Best medics I know were always able to do what? Flex. I ain't telling you to break no dang protocols. I'm telling you to learn how to flex. Not break rules, but give you an example. Grady used to get on us about taking patients to the warming shelters, and you didn't want people in the truck that were not being transported to the hospital so we can bill them. But I'm not about to let this man sit here and freeze to death, especially when we have about 20, 25 hypothermia deaths per year. So moving posts, it's on the way. Make it happen. Other causes of inadequate breathing, we're talking about severe infection, trauma, a brainstem insult, poor oxygen environment, renal failure, respiratory muscle impairment, central nervous system impairment. I like it. I like it. I like it. I like it. So inadequate breathing, how do you actually tell there's inadequate breathing? Opening the airway is one thing. Hearing this sound, you actually have to listen to lung sounds. That should be one of your first vital signs. What? You keep adding vital signs, Josh. You're telling us to 12 lead everybody, blood sugar everybody, listen to everybody's lung sounds. I'm gonna have to work on scene. Why? Roby, recruit.
Yeah.
Yeah. Do you trust Proby with your job? Why not? I know a lot of you are. Tell me why. You trust his vital signs over yours, paramedic. Because you're lazy? Tell me why.
You're nervous?
Who's nervous? I'm talking about when you're a paramedic, you're going to give this responsibility to your Proby?
I mean, I'll let him do it. If they're doing it.
You trust him?
I'll go back and check. If it's somebody you can work with for a while, I'm ready to go.
Okay, fair. If you've trained them and they've been on the job with you a while, you can trust them. I would always say double check though. Double and triple check. I'd get the first set myself and let them compare.
I bring you another projector to borrow.
I don't borrow, I keep forever.
Yeah, I'll let you borrow it.
I expect it. So take your vital signs, all your vital signs. A blood sugar is a vital sign. What's Grady gonna ask you for immediately when you get there? Vitals and a blood sugar. Did you get a sugar? Did you get a sugar? Get a sugar? Get a sugar? Yeah, I did. You gonna feel silly if you didn't get one of this actual blood sugar problem? He's having a stroke. Survey says nah. Low. Survey says no. So all these are vital signs. Ugh. Hopefully when I'm done with you, you'll be doing all these vital signs and doing a full head to toe, even on medical patients. But why?
Medical issues.
Medical issues too. Could be something else going on. That's how you find fentanyl patches, which are narcotics. No wonder he's not breathing. Oh, a nitro patch. No wonder his blood pressure's on the floor. Oh, an open septic gangrenous wound. No wonder he's septic. Oh, an insulin pump. Ah, he pooped himself. Whoops. Taco Bell? Yes. So feel for air movement. Observe chest symmetry. Note any paradoxical motion. Now that's another buzz term. Where does it push you? Flail chest is where it should push you. How do you fix a flail chest? We'll go ahead and talk about it. You are paramedico now. Not anymore, guys. That's old stuff. Positive pressure, ventilation, and fentanyl. So positive pressure, so either BVM or a CPAP to push that thing out and hold it there so it's not moving. It moves in conjunction with the chest. That is the new, this ain't new, it's 3 years old for sure. But that's the accepted way to treat a flail chest now. Depending on how bad they are. Do they need to be bagged? Do they need CPAP? Are they more conscious or less so? Go ahead.
I'm just about to ask, depending on the consciousness
Yes.
of the patient, trying to bag somebody that may have a flail chest, they have just doing the kind of.
They're not going to let you bag them.
They're not really back.
So if they're conscious, CPAP. If not, bag them. Because we don't put CPAP on people that are unconscious or altered. CPAP is not ventilation. Ooh. CPAP is not ventilation. It is oxygenation. CPAP is oxygenation. And how it works, good. But it is not ventilation. Write that down. So here we're mentioning the eyelash reflex, evaluating their breathing, coughing, sneezing, gagging. Gag reflex is also tied to your eyelash reflex. What did I say about that earlier? What do you think there, Martin? So if you can tickle their eyelashes and they have a reflex, like a blink or whatever, they have a gag. So they would have to send signals via the nervous system. They could probably measure when the signals are being sent. So like, but also Valentine's is tomorrow. If you got a new date, just like you got something in your eye, just test it real quick. She blinks. Get a new date. My boy's sick. I gotta go. But if she don't blink, wife her. Sighing, hiccuping, all these are other types of reflexes. They don't know why hiccups exist. There's no physiological purpose. It's just diaphragmatic spasms. They have no purpose. Science hasn't figured it out. I'm sure there's a purpose. We got to think the Almighty was like, you know what? You know what? Actually, let's back up because I know that guy's got a sense of humor. I mean, obviously, I'm kidding, but I wouldn't put it past to slide one past him just to mess with us. You gonna eat too fast, huh? Look at you now. All right, so we talked about respiratory patterns. I don't feel the need to beat on that anymore. So assessment of breath sounds. So we'll learn in paramedic school that placement matters. Landmarks matter. Where you actually place your stethoscope actually matters. Raise your hand if you've just actually kind of placed it on the chest and kind of listened. I wasn't being truthful. I was testing you. I made you more comfortable by raising my hand. Now look at you, all exposed.
Raise my hand.
Okay, fair. So let's look at it. So listening to the patient's airway and breath sounds at the second intercostal space, third, fifth, and seventh will tell me what? Upper and lower lobes. Listening to their back, between their scapula, down farther this in the cervical area, then below their scapula on the other side will give me a good, clear resignation of what? Upper, lower lobes, front and back half of the lung fields. Is it possible to have, and the reason we listen to all these lung fields is why? They could have isolated lung sounds that are demonstrating isolated issues. Let's say the patient has fever, chills, is coughing up yellow and green sputum, and they have like a lack of lung sounds in the very back lower lung over here, right below the scapula. That's one spot of consolidated what? Mucus that has got infected that we call now pneumonia. Everybody with me? Are you really? Are you really? So duration matters. Length of time you put in matters. Are you? So inspiratory, expiratory phrases. I'll explain. IE ratios. It should take you about 1 second to breathe in, 2 seconds to breathe out. You dig? That's the normal IE ratio for everybody in the room, mostly, except for that guy that we talked about that's at the other class that takes 10 minutes to breathe out because, yeah, him. So what about somebody that's got chronic obstructive pulmonary disease or obstructive airway disease like asthma, COPD, emphysema, chronic bronchitis? Their expiration is longer. Now, this translates to when you have them on a vent or when you have been bagging them and you start to have a harder time to bag them. And you know they got COPD. They have air trapping. So on a lot of times when you are starting to have high pressure alarms on a vent with a patient with COPD or asthma, they have air trapping. So we need to change their IE ratio from 1 to 2 to like 1 to 4. 1 to 4 gives them 4 seconds to expiratory and breathe out versus the 2 that we have. What's another thing you can do? If you've got them bagging, pop the BVM off, push on their chest. That gets that extra stuff out of there. Sounds simple, right? Because it is. But it's like, I hadn't heard that before. It's not rocket science. There's air trapped in there. There's squishy little bellows in there. Remove the obstruction. Push on the chest. Done. So if you're getting airway pressure alarms from your vent, or if you're starting to have decreased airway compliance, and compliance means the ease in which it is to bag them, then there's something causing obstruction. There's air trapping or breath stacking. Breath stacking means that they're breathing a little bit on their own now, and it's starting to stack their breath with your breath, increasing pressures. How do I fix it? Push on their chest. If they're starting to wake up and breathe too good, pull out the old reliable, Versed them back down. You with me? Lovely. Lovely. What about breath sounds? Do they matter? It ain't easy being wheezy. Wheezing be a continuous, high-pitched kind of whistling sound coming from the lower airway. There's going to be questions on the registry, and I'll probably give you questions as well about name that airway sound. Dun-dun-dun. Is it upper or lower? It is very important for you to be able to differentiate on paper and in real life the difference in stridor, wheezing. I would say crackles. Honestly, though, wheezing was easy to hear, but the rest of it, it's kind of tough. It was either wet lungs or dry lungs to me. It kind of just told me what I needed to do. Is there absent lung sounds? Bag them. Is there one absent lung sound? Probably dart them. Is there stridor? There's something in the throat. Gurgling. There's fluid in the throat. Snoring. There's a tongue in the throat. Wet lung sounds. CPAP. Keep it simple. Kiss it. Keep it simple, stupid. Sometimes you can hear like pleural friction rubs where it sounds like they're just like, y'all hear that? Not really? Well, I'm sorry, you got bad ears. But basically you can hear the tissue moving together, causing a sound to occur. What about tools to play the game? All right, so pulse ox measures O2 saturation of hemoglobin. Now, this thing, it'd be lying. Why? What can throw it off? Ooh, these nails, girl. Pretty nails, cold hands, poor perfusion, patient being in shock. What's the first thing your body's going to do in shock? Shunt blood from the periphery to the vital organs. Why am I pale and cool and clammy? Because your body is shunting the blood to the more important organs. Can't trust this thing. You must learn how to assess your patient in a more global sense, where you're looking at their airway, their breathing status. You're doing a minute ventilation. You're seeing, are they adequately able to meet the metabolic demands of their body? Pulse ox can also be thrown off by carbon monoxide, because that little thing's only measuring to see if there's something attached to hemoglobin. Doesn't matter what it is to it. Your service should carry a secondary oximetry monitor called a CO monitor. It looks like a pulse ox, but you hit a little button, it goes from pulse ox to monitoring CO. Do y'all have one, fire department? You know how to use it? You're the only person that's come in here and said that you knew how to change it.
Well, it's only because ours changes to the CO all the time and we have to go back and change it back to Mario too.
So it's a fluke that you would know that. I'm not being mean to him. I'm just saying it's a fluke that he knows that because in the last
Otherwise.
3.5 years, nobody else has known that. Does anybody carry the portable handheld one? Y'all do? So y'all carry the one from CVS that cannot monitor CO2. So you don't carry the one that can actually hit a button, it can measure CO2. Wow.
All of our, I think everyone.
So venous pulsations, patient movement, poor perfusion, bright ambient light can throw it off. There's a lot going on there. So co-oximeter will be the one that can measure your CO2 levels. It is my suggestion to have that on your engine since you are a fire department, but also if you're an ambulance company, you need to have it. Why? So you can actually measure and see if somebody's got CO on board. Let's say you're in a house fire with Cap there. He pulls you out. We should be able to measure it. Come on. So somebody does have carbon monoxide poisoning. What's the fix? Hyperbaric chamber is the real fix. So where do you need to take them? G unit. What's that? That'll do it. St. Joe's. St. Joe's can do it. Grady can do it. I've been told, I don't know if this is true or not, but they actually have medications they can push now that will bind to it and get it out of your system. I haven't seen it, but I've heard it from 2 different sources, so that'd be pretty cool. Y'all not carrying that, but Grady would have it. Or another mid-major hospital. Now, what about peak expiratory flow? I personally don't have the time or connotation to do this, but again, you got to remember that when we are looking at this data, we're looking at perfect, well-funded, great ambulance services. Y'all are the leftover crap. It's not your fault, some of you. But they would have a way to measure peak expiratory flow to gauge if a patient's lost some or if they're minimally performing. What about arterial blood gas analysis? Which one of y'all is carrying blood gas analysis equipment on your truck? Do you have an iStat to measure point of care labs? What? $20,000 for a used one, yeah. So we could actually take blood gases on patients. You stick into their artery, suck some blood right out of their artery, see what their blood gases are, what their CO2 levels, their partial pressure of dissolved oxygen is. All that, man. Be nice. You know what you got instead? You've got the poor man's blood gas. What's that? Entitled CO2. Carbon dioxide. Carbon dioxide measurement. This detects exhaled carbon dioxide in the air. So it is great for determining ventilation adequacy. How? I can see if I'm hypoventilating or hyperventilating based on the numbers and figures. Normal levels are 35 to 45. If I've got a reading of 55, I'm hypoventilating. You can see if the bronchioles are spasm if you have waveform. If you have waveform capnography, the different waves change and can tell you if there's something going on. What she's mentioning is that the appearance of bronchospasm or an asthma patients mostly, you'll see it look like a shark fin. Instead of like the normal little square box it's got, it looks like a shark fin. It means bronchospasm. The patient's probably having an asthma attack. You could tell all that with capnography. There's no better way of confirming advanced airway placement. So get an ET tube. When we get to intubating, I'm going to make you tell me 6 different ways to confirm a tube every time you get a tube. Let's start with lung sounds, watching it pass through the cords. Capnography, listening to epigastric sounds, condensation in the tube, and a esophageal bulb detection device. All these are ways to check and tell. Check and tell. So you're seeing where CO2 monitor is pretty cool, right? So they have different forms. Colorimetric. So colorimetric is only good for a couple breaths. It's like chemical paper stuck in a little plastic square box. It is meant to tell you, yes, you're in the trachea, or nah, you're not in the trachea. Digital is giving you a figure readout. It'll be a number between 35 and 45, hopefully, but if not, it'll tell you that they're breathing at 20 of capnography, which means that they're hyperventilating. You're bagging them too fast, too hard, too much, too often. Slow it down. And digital / waveform gives you a figure and also gives you the waveform of their expiration, then they're breathing in. Expiration, breathing in. And again, based on the shape of the waveform, it can tell me what's going on inside the lungs. Like, again, the shark fin indicating what? Bronchospasm or an asthma attack. What does the colorimetric one look like? Voila. Looks like a little square box. So, yellow is mellow. Hold up your hand. Slap yourself. Wonderful. Why?
So irritated.
What's he irritated with? Shut up, quit asking questions. I hear him muttering back there. I enjoy it. His annoyances are wonderful. I'm ready to eat lunch. So readings after about 6 to 8 breaths, they're obsolete. Why? The paper's used. If there is CO2, it will change color. If there's no CO2, it will not change color. It will stay purple. So let's do it again. Yellow is mellow. That means good. We got CO2 hitting this bad boy. Purple, nurple is not a good thing. What's a purple nurple? It's a titty twister. Is that very good?
No.
Don't answer that, some of you. You might be into it. If so, send me after class. So yellow is mellow. It means good. Purple nurple, bad, pain, owie. So yellow means that you got CO2. Purple means you do not. It's pretty simple. It's only used for what? Tube verification. After 6 to 8 breaths, it's useless. You must replace with a quantitative device. What does that mean? A digital device that tells me a figure. That tells me a figure. Ugh. So capnometry, capnographer, all these are ways to measure this exhaled CO2, either with a numeric reading or a graphic representation. Numeric will be capnometer. Capnographer will be what? It makes a graph. It makes the waveform. So we have waveform and digital. Waveform provides real-time CO2 information. It's also a good way to protect yourself. When you get the ER and they just jerk your patient over to the bed and it knocks your tube out, you were in the stomach the whole time. Look at this waveform reading, lady or guy. Showing I was actually in there and that your rough handling of the patient before I said go is actually what caused the tube to dislodge. Why do I tell you that story? It happened. You weren't even in the tube. Didn't even wait for me to get my hands on the patient. 1, 2, hey. Just snatched the patient. There went my Rosk. But that hospital is no longer with us. AMC's out. Finish him. So about quantitative waveform, recommended for monitoring of initial and ongoing placement. So once you've got an ET tube placed, it's recommended to have waveform. Well, you can see how the flow goes. To notice and know if there's any kind of contours or baseline issues or waveform pattern issues that you should stop, that you should see. Let me tell you something about waveforms when it comes to EKGs or capnography. You know, I'll take it a step further. Let's take up lung sounds, heart tones. Learn what normal looks like or sounds like, and then when there's something abnormal, you'll notice that break in the pattern. Breath sounds is a great idea. You want to get good at breath sounds? Listen to a bunch of normal ones. When it doesn't sound normal, be like, hey now, I don't know what that is, but it ain't normal. You can at least be tipped off there. Same thing applies to your EKG. Same thing applies to your waveforms. Find what normal is, and you can tell when it's not normal. That's your first step. And again, as time goes by, you'll notice specific patterns and where they correlate to and what they mean. But at least initially, you can be like, that's not normal. So end-tidal carbon dioxide, I like it. We can see the changes in waveform, the rate and the rise of carbon dioxide. It's a great measurement to indicate the effectiveness of chest compressions. I said that earlier, did I not? You can see how well your compressor's doing based on the amount of carbon dioxide you're getting back in your waveform and your digital readout. Anything over 10 is in. Anything less than that, go do some push-ups because you suck. Or they're probably tired. I don't know about you, but I've got a battery on me. I got a paramedic battery. I can go and go and go. But eventually when I hit stop, it's stopped. So other forms of end-tidal carbon dioxide measurement. Let's take a look at, oh, hey now. They have it in a nasal cannula version. In a nasal cannula version. That is wonderful. Right. That means the patient's having an asthma attack. I can actually see how well they're doing with their ventilation status. I can see the presence of bronchospasm as it exhibits its shark fin appearance. Now, what about this other guy on the other side? That goes for advanced airway. You can stick that where? On the end of your ET tube in between your BVM. So reading waveforms, it's going to take some time, but it kind of flows in the opposite way than what you'd be used to. So looking at this right here, this upslope right here is actually expiratory phase. This is them breathing out. And this waveform will be attached usually to a little graph over here. You can see the graph right there. He's probably about what? There's 40 right there. So that's probably what, 35, 37? Is that normal? That's a normal waveform. So we got the initial phase of exhalation. Exhalation. This is the, the plateau phase where the alveoli are pretty much standing still. They're keeping a constant pressure to push out with, but they're not collapsing upon themselves. Remember, the lungs expand and they contract and squish the air out, right? This is that kind of plateau phase where they're not going to collapse or close anymore or push anymore because they don't want to do what? Close. But no matter how hard you try, you're going to still have a residual volume in the bottom of your lungs. What does that mean? There's going to be a little something down there left over to do what? Keep them open. And then you have the inspiratory downslope, which means what? This little area right here is when they're starting to breathe back in. Everybody got that so far? All right. I like it. So abnormal capno waves, hypoventilation. They're breathing too slow. Will be tall and slow. Hyperventilation. I just want to show you because I don't care. Look at here. See the big slopey things here? He's got a what? 65 capno reading, and he's breathing twice. Is that hyper or hypoventilation? Is that rocket science? Is it pulmonary science? Hey, totes is. Now let's check this dude out over here. His reading is about where? Like a 25, 30? Maybe less than that, because 50's here, half of 50 be right there, right? Where's he at? Probably like at 20. So there's that. Now, what about this feller over here? What's that? Da-da, da-da. Da-da, da-da. Da-da-da-da. Remix. It's a shark fin. Now, you were probably expecting a more pronounced perfect shark fin, right? Sometimes they do look better. That one's not a great one. I'm not gonna lie. I've seen better. But that is a shark fin. That is a shark fin. So, and then this guy. You see how that other half is coming up off the bottom? That means incomplete alveolar emptying. Breath stacking, very good. So they're breath stacking. It's not returning all the way to the baseline because everything's not getting out. So there's still CO2 left in there, and you can see it being left in there by what? We're not returning to baseline. Then the next one's a tad bit higher. And the next one's a tad bit higher. Oh, y'all buying into it today. I like it.
If that bottom line continue to go up, is that where you pop them?
I would. Because eventually it's going to look like this guy in figure A there. It's going to look like figure A because it's going to be like, boop. And we're going to have probably hypo ventilation occur. Now, one of the good things about capnography also is that it can tell you if you got a Rosk back. How? I got a reading of 10, it suddenly shoots up to 20, 25, 30, 35. Oh, sorcery. I'm filled with necromancer power. So you can tell if you got a Rosk back. So MVP of vital signs again, metabolism, ventilation, perfusion status. You cannot beat it. It's the gold standard for operating in paramedicine. How often are you seeing it being used though? Only on arrest? Is this thing only useful for an arrest? Are you even seeing it on arrests being used? Sometimes when AHA says this is the gold standard for operating an arrest, and we're saying sometimes. Not even worth it anymore. I just wanted attention. I just wanted attention. Now, what happens if suddenly I have a blang that you could be in the guts? Hey, could be. Play your cards right. Oh, you got it. Inadvertent extubation. Inadvertent meaning what? I wasn't intentional. I have lost the tube, or the patient did. Or there's a tube obstruction. What could it be? Could it be perhaps you got the Thomas device clamped too tight? The commercial tube holder that you use to hold that thing in place, you could have it tightened too much. The patient could be what? Biting on it. Patients do bite. Fingers out of the mouth. That's like the fourth time I told you today. One of you's gonna get bit though. You're like, yeah, I told you. I told you. So keep your fingers out of your mouth. You have bite sticks for a reason. And if you put the commercial tube holder in there, it's got a bite block on it built in. If you carry commercial tube holders, who doesn't? That should be the bare minimum you have. If not, we can talk about how to make a chevron tape thing. It's better than nothing, I guess. And when Kat comes for pediatrics, oh man, she showed us a really cool trick last year. But plastic's not going to pull on plastic. It's going to adhere and stick and have a grip on it, right? So they don't really make commercial tube holders for babies. She showed us how to make one out of dang O2 tubing, and like you could take the mannequin in there and pick the kid up like a fish like this and shake it, and it would not come off. It's pretty cool. That's some of that old hick medic stuff from the med down there in Macon for the Children's Hospital. This is me now. That'll probably be you soon, especially if you're riding at Grady. You're over there flirting with the nurses. There's your partner getting beat up, and then you're still on scene. Screw you guys, I'm going home. So airway management, it's only going to reach the lungs if there's a clear trachea. How many pipes you got in the throat that lead to the lungs? One pipe to the lungs. In a compromised airway, clearing that airway and maintaining patency are vital. You have to find it early, be aggressive, and reassess. I've said that a few times a day. Is it going to stick at some point? Find it early within the first how many seconds? 30 seconds. Aggressively treat it. Reassess it. Reassess it, reassess it. How often should you reassess, Thornton? Registry has their thing, I got mine. I explained earlier with Whitworth's wife, with Hardin's wife, with your loved ones. Would you want somebody to check on them every 5 minutes? Or to just keep their eye on them? Because honestly, let's say when y'all get your ambulances up, City of Atlanta, Station 17, I don't even know where y'all are at. How far are you from Grady? 10 minutes, right? Can you not hold attention for 10 damn minutes with my family member? It's very possible. And if you know a lick of what you're doing with your documentation, when you get to the ER, you're really only going to need signatures anyway. Because as a paramedic, I'm paid for this. I still use these from time to time, but if you train the people around you, so you're having trouble breathing, I'm making all this happen as we go, as we flow, as we treat, as we street, as we move. But when I'm back there alone, it's me and you, mano a mano, not cutting corners, not skipping steps. I'm finding the problems. I'm fixing the problems. I'm aware that if things change, I see it happening. I know some of this may sound repetitive. Good. I have to have a time where I leave fluff to the side. There's good to know and there's need to know. If I'm repeating something, it's need to know. Positioning the patient. A lot of unresponsive patients need to be log rolled and put into the recovery position. This is called what? Left lateral cumber. This is the recovery position. It's also the drunk position. Why? They don't aspirate. Have you ever worked a drunk code? No. I've arrived to a lot of 48s though, where they're dead already. I've had a couple where I actually had to work them because they were still gasping, but by the time I get there, a lot of times they're already dead. Their friends left them. They're laying on their face. They vomit while they're sleeping. They inhale it. They code. Easy paperwork. Deal it. Police matter. So when we transport patients, let's say the drunks, let's put them on the left side. When we transport pregnant people, left side. Why? Say that again. Way to copy what she said. Way to go, AFD. No citation needed, huh? Plagiarism. I have a plagiarism checker, just so you know. Anyway, so left lateral coming for pregnant patients because they have supine hypotension syndrome. The fat baby sits on the inferior vena cava, reduces blood flow to the heart. Their blood pressure falls. Put them on the left side, don't have that problem. So now we're talking about manual airway maneuvers. I'm going to actually, at this point, so airway obstruction, things stuck in the throat meet. Typically middle-aged or older. They may have dentures, might have alcohol on board, might be in Buckhead, might be at some ritzy little place. Maybe I've been there. So signs may include choking. Universal choking sign is what? If I got it. Gagging. Sloss. Tickle your eyebrow for me. Oh, he's a keeper. Strider, what is what? Oh. What's that? Loud, high-pitched crowing or whistling indicating a what? Partial upper airway obstruction. Dyspnea, though. So the registry will not say trouble breathing, they're gonna say dyspnea, which means difficulty, trouble breathing. Aphonia or dysphonia, what does it mean? Inability to speak or difficulty speaking. Let's talk about the medic that's so set on getting a history out of a patient that they are not treating their, I need your name, sir. He can't breathe, you idiot. Treat him first. You hear the wheezing across the parking lot, right? But you've seen that medic, right? So concerned with his documentation. You're here for the patients first. So don't be that medic. I mention it so you don't be it. So laryngeal spasm and edema. Spasma is spasmodic closure, where it's just a collapsing of it. Occludes the airway. Causes include intubation trauma. What? Does that mean you could cause it? Way. Yeah, you could. How? By doing a crappy job. Being too rough. Not using enough lube. Not being gentle. Not buying them chocolates. You should have brought them flowers and held their hand. So also extubation. Somebody pulling that tube out or something pulling the tube out. Patient starts to wake up because you did such a good job. That's something in my throat. That will damage that larynx, and it will do what? It'll spasm closed. So guess what? They extubate themselves. They damage the larynx. The larynx is like, oh hell no. Collapse, close. Now what? I can't get the tube back in. Live, damn it. It doesn't actually work like that. So some Versed can relax it, but also laryngospasm, you could try the old touch and go. How does that work? The tip of the ET tube, the closed larynx. Come on. Come on. You hold it there and just put pressure. Okay. It's a joke, but it's also the truth. You heard that in paramedic school too? No? You can just put some pressure up with the ET tube there, right there on the larynx, and that pressure will cause it to, oh, all right. Just once though. You still gonna respect me, right? Yeah. Code Sam. So 2 options there. Try some Versed, or you can try what? Just the tip. It's too easy, actually. Now, laryngeal edema, the glottic opening is narrowed or closed because of epiglottitis, inflammation of the glottic opening. We say epiglottitis all the time, and we say kids get it. They do. Bacterial infection, high fever, but guess who else can get it? You! More rare, but it does happen. Don't think it can't. Tall tale sign as far as registry goes. Drooling is the tall tale sign. Secondary will be what? There's going to be some stridor. Differentiation between that and croup will be the Silbart cough. Anaphylaxis can cause an inhalation injury. What have you inhaled? Toxic hot gas. Somebody Dutch ovened you. That's assault. So you can also relieve spasm or edema with what? You can aggressively ventilate them. All right, ho. Now, a lot of that's not going to go into the trachea, but some of it will. And half of nothing is nothing, but half of something is something. What about forceful upper jaw pull? Remember I told you the fish hook? You can break that thing open. If the jaw's clamped closed, or if the larynx is spasm closed, you can break that thing open with the jaw thrust pull. Maybe relieved by muscle relaxants. You got any Versed on board? You should, you better. So it may reoccur. If it has spasmed, it could spasm again. What's the best way to protect against that? Have a tube in the way. I don't tube people for the fun of it. I tube it for their protection. to protect their airway and guarantee patency. What does it mean for something to be patent, Martin? Open and ready to go. What about laryngeal injury? So a fracture of the larynx increases airway resistance by decreasing airway size. So you had a hole this big, bear with me. You broke the larynx, the voice box there, what now? It's broke. So now the hole's this big. Hello. Been doing kegels? Penetrating and crush injuries, like what? Throat punch. Or this happened. Erotic asphyxia. Oh yeah. I show up for a cardiac arrest. Guy's sitting there done hung himself. Has on the black leather thong thing and like pierced nipples and just everything. He's just sitting there like, I'm like, I guess I should cut him down. Sir. And I had to just ask him, how do you use this thing? Damn. What?
Yeah.
I don't gloves. It's girthy. Lord. I love Atlanta. Can't make this crap up. Aspiration. Usually gonna kill them. It increases mortality a lot. Can obstruct the airway, destroy bronchial tissue, introduces pathogens in the lung. It's not always the fact that they don't immediately drown and die. They could get pneumonia and die, or get septic and die. It decreases their ability to ventilate, depending on where that pathogen goes. Now, what about a foreign obstruction? You know, I think that's coming up. I'll wait. But also, you need to have suction available. Why? If you hear wet, gurgly sounds from the upper airway, you need to be ready to get that out now. Like, not later, now. Aggressively, quickly, fastly. You should already have that ready. When you go to a respiratory call, and again, Grady's the worst in the world at this, I'll admit it. Especially if it's last call protocol. They run to the front door with nothing in their hands. Nothing's in their hands. You know what should be in their hands? Everything you need for a war. Everything you need for a fight. So portable suction, intubation equipment. What else? Respiratory drugs. All the stuff you'd need for a fight should be right there ready. And the day you don't take it's the day the boy cried wolf and there's a wolf there. Don't let them catch you slipping. So obstruction, patient's responsive, able to exchange air, usually has a noisy respiration or coughing. You should leave them alone. Watch them, but be prepared to intervene. What does that mean? There's definitely something in their throat. However, it ain't killing them. They can move air. It ain't great, but it can be made worse by you doing what? Digging in there. Hold still, sir. I'm not really. And then Sloth's be like, This weird one likes it. So, if it ain't broke, don't fix it. If it's not a trouble or threat to their life, don't mess with it. We talked about steakhouse syndrome the other day. That applies to when something's stuck in the esophagus. They can actually give what drug to relax the esophagus? Glucagon. There you go. What about a severe obstruction? They can't talk. They can't cough. They're grasping their throat. They're turning cyanotic. They're making frantic movements. Cough is weak and ineffective. Anybody ever choked on something and thought you was going to die? Nobody? Scare you? Fishbone? I can see that. Stafford? Nothing. You chew your food. Actually, I cut it in small little bite-sized pieces, like mommy taught me. Chew, chew. You know what almost got me one night? Nah, them damn Animal Pack workout pills. You know Animal Packs they sold at GNC? Some things were like this damn big. That big around. I was at the house by myself too. I started seeing dark spots. I'm like, oh hell no, I ain't about. I got on top of the counter, the kitchen counter, swan dived off the back, and I hit my back on the Saved my damn life. Hey, I was still thinking clearly. Had to make it happen. There was a bodybuilder a couple years ago named Dallas McCarver. Very nice guy, very well, huge dude. He's probably going to be Mr. Olympia one day. He died by choking on chicken. There was nobody at home with him. He was just trying to force feed himself to get big and strong, right? Choked on chicken. That's terrible. He was very young, like mid-20s. So if they is choking and they're conscious, Heimlich, when they become unresponsive, CPR can still move that foreign body out. Now, what if you can see it? Forceps. Now, what if you know it's down there and you can't really get it out? What's that? That's what I would do. Now, that could create pathogens and a whole slew of problems later, but it fixes the problem now. You can push it farther down. You got two branches of lungs. One pipe is clogged. You push it down, it's going to go left or right, most likely right, path of least resistance. It'll probably take up one of them bronchioles over there, or bronchi. Cool. Because I can still ventilate the left lung and some of the right lung. Is that better than death? Yes. Yes, it is. It's much better than death. So last resort, push it farther. That'll be an ER issue and an antibiotic issue for them to figure out later. My job is ABC 1, 2, 3. You live till you get to the hospital. Sign here. Thank you. Bye. Your problem. So begin treatment immediately. Suction if you feel like you need suction. But the problem is with some foreign bodies is that, especially steak. Steak is the worst. Steak is sinewy. You try and pull a steak out with the forceps, it'll come out in pieces. Come out in pieces. You gotta be careful of that. So you can push it down. Ain't better than death, though. I'm gonna try and pull it out if I can, but again, if I can't ventilate, I gotta try and intubate. And if I can't intubate, I'm gonna have to try and ventilate. And if I can't do neither one, I gotta criconate. Slit, tube. Also, when you're taking the National Registry test or any test I give you in here, you're not a Georgia medic. So surgical cric is on the board. RSI is on the table. You have that ability on paper. When you become a Georgia medic, of course, all that goes away. But when you're taking tests in here, just remember, you're a National Registry medic. That's how they're going to test you. That's how I'm going to test you. Keep that in mind. So another thing to think about is anatomy. I told you about big bullfrog neck. You ever seen Varsity Blues? Remember Billy Bob? Big old ham hock looking fella. Sumter County Fair. Picture it. Summer of 2010. Patient is unresponsive and had choked on a hot dog. Billy Bob didn't choke on a piece of hot dog. He choked on the whole damn thing. I could see it. So I grabbed with the forceps. I pulled out an entire hot dog out of this man's trachea. I bag him for not even a full minute. He's back too. And he begins to thank us. He didn't ask for the hot dog back.
No, he did not.
I cannot make this crap up. I flipped it in the trash can and said, no. I wish I could make this stuff up. But alas. So there's your forceps. I'm going to give you some play time with that here soon. I'll probably drop some random objects in the mannequin's throat and let you just dig with them. You just need to practice your dexterity. If I can borrow the salad mannequin from our dear friends across the pond, that'd be a fun day for y'all. What is a salad mannequin? Oh, Lord. Why? So a salad mannequin is where you pour salad dressing down the, I'm just kidding. It stands for something, laryngeal, blah, blah, blah. I forgot. But basically, it's a mannequin that has the ability to vomit while you're intubating. So the airway will fill with fluid and liquid. You got to learn how to suction and intubate at the same time. Very fun. $20,000 mannequin. Obviously, I ain't got one. So try and borrow one if they're feeling cool that day. Now, what about O2 therapy? Oxygen therapy, knowing when and what to put the on the patient. I don't feel the need, as you are already EMTs, to really dig into sizes and things like that, like a D cylinder, M cylinder, all this. I think that you should be well aware of that right now. You should know that the small O2 tanks have limited supply, right? The big ones are for longer transfers and vent calls. So in the city of Atlanta, does anybody carry a big cylinder anywhere? Grady don't carry one. They only have the little ones. You got like 3 or 4 little ones, and then you got to go resupply.
I know Central are big ones.
They do. AMR might have big ones on there, but they also run transfers too. Big cylinders. Sir? Showa truck probably has them. Stroke truck might have them. But Grady's mindset is, we got to hop and a skip. We're not going to carry a big cylinder and spend all this money for that. But they will give you like 3 or 4 little portables though. And if you need more, they can always meet you at the hospital. Supervisor can with more portables, or Memorial Drive ain't right over there. You can swing by, resupply. I'm gonna use the restroom, eat a snack, and then go back to service. You know, so I'm gonna take care of you, fam. I'm trying to be here for you. That's 12 hours and probably 16 to 17 calls you're gonna be running. But you know what? Let me give you this to you now. You can only run 1 call at a time. So the board having 50 stacked should not stress you out. Why? I'm responsible for this call right here, right now. When I'm done with it, okay, here's another one. Here's another one. I'm only responsible for 1 at a time. Now, if I'm being system mindseted, though, I will try and turn them over quickly or listen to radio traffic and, look out for my other members of my crew. If I hear a code 11 go out, that's their mayday. That means somebody's getting their butt whooped. I need to run and gun and go over there and help that out. However, their new Zoll software is pretty much silent dispatching now. Way, way less radio traffic. Like pretty much I'm on scene with a button. I'm leaving for Grady with a button. I'm doing this for a button. Oh, there's a button for GPS and it takes me where I need to go. It's pretty cool. I like it. A lot of people didn't like it. That's pretty cool. I like it. All right. Any questions from me? I'm going to have to put a pause in this one for today. It's a lot of material. I already can tell I've lost some of you. We still got lots more to go. So this is probably going to be it for Airway 1 lecture. Tune in for Airway 2.